air track, it has been proven to increase the first time intubation success up 15%. 15%. So, basically, you guys have all seen these in the rigs. They're in hard cases to protect them. Once you pull them out, you will notice that this is flexible here. Try not to pull on it. There's fiber optics in there and they will break. So place them when you're not using them. Keep them in the case to keep them safe. Next to the case, you'll see the plastic sleeves that are in the bags. Alright, to start the air track, you're going to take the sleeve out and you simply just place this into the sleeve. There's a little pin on the inside of your sleeve that actually goes up into the air track, and that's what turns it on. There's no way to turn the fiber optics on without putting the sleeve on. Alright, now I charge all the sleeves every single week. Once you click it in, you'll see this light flashing here. What this is an anti-fogging mechanism. This can last, depending on how cold it is outside, it can last for anywhere from 5 seconds to 30 seconds. So once you know you're going to use this for intubation, go ahead and put it on and get it warming up. Once the light goes solid, it's ready to use. Alright, so I charge these every week on my shift. The charge will hold for about 60 days if they're not used. Once they're used, they still hold for about 30 days. But just to be safe, I charge them every week, so you won't have any worries that they're not going to be charged. The point is, I don't want you checking these on your shift. Once you connect this into the plastic sleeve, that counts as a usage. These fiber optics are only good for 50 uses, and then you have to buy new ones. So they will be charged. You don't need to check them. Only put them together when you're actually going to use them. All right, because they're not crazy expensive. They're about $100. But again, you only get 50 uses. So if you're checking them every day, in a month, we're going to have to buy new ones. So once you're ready, you're going to put it on together. Wait for the light to stop flashing. There's a little eyepiece that comes with it. Okay, you just pop the eyepiece on. Alright, and then what we're going to do is, we don't have a video for this. This is actually direct. You're going to directly look down into this. So to use this, you're going to look down through here, through the mirrors, and you'll see a good view and advance your cord. Okay, select your tube size. This will go anywhere from a 6 to it says 6 to an 8. 8s are very tight in here. 7.5s work well. You can, I put an 8 through here, but it's tight. Select your tube size, and you're going to need a lot of lubrication. So lube both inside the track here and the tube itself, and then you insert the track directly, or insert the tube into the track. No stylet in your tube, right? Because it's going to conform to the track that's built, so you don't want a stylet that's going to change the path at all, because you want it to take its normal path. Your only other option, other than, so if you're not using a stylet, you do have the option to use a bougie, which I'll get one out for when we practice. This is all your preference. When I use this, I preload a bougie in every time, so that it's there, it's ready to go. What you'll notice in patients a lot of times, especially until you get familiar with this and comfortable, a lot of times you'll have a pretty good view of the cords, and you'll go to advance your tube, and it's just a little bit low. You can't get it to go up up through the cords. So I have my bougie already preloaded, and if that happens, I just push the bougie through while I'm still watching it, and with the tip of the bougie, how it's curved, you can spin it and push it right through the cords. It just gives you an added opportunity, and then you don't have to pull back out and get more equipment. So I really recommend to just put a bougie in there. If you don't use it, you don't use it, but if you need it, it'll be there. So once you place this in, the best thing I can tell people, you want to make sure that your tube is not farther past your tip, or else it'll get hung up. Usually I'll reach in and grab their jaw and their tongue and kind of pull it forward just to slide this unit in behind the tongue. And I usually put it in and kind of let it just drop and sit in place. It'll kind of seat itself where it wants to be, and all you do is grab it with your left hand and pull straight up, just a little bit while you're watching. If you don't have a good view, it's all straight up and down. You don't want to rock this thing. So the way this is angled in there, once you put it in place, if you start to rock it, you're going to get way too far. It's going to go way past the cord. So if the cords are sitting here and you're below it, if you pick straight up, you'll come into view. So it's all up and down. That's probably the hardest thing to get used to. With the laryngoscope, you're usually rocking back farther, picking up farther. This is just straight up and down. Once you see your cords, you can advance your. Once you've advanced your tube, slide around here. you advance your tube, the best way to take this out without compromising the tube is to hold the air track, grab your tube with your right hand, and you're going to pull it out to the right, okay, and it snaps out of the track. And what I'll do is I usually put my thumb on the tube in the corner of the mouth while I pull this out. That just kind of holds the tube in place to make sure we don't end up pulling back. Is there any questions on that part?
Do you have to use the track, or can you visualize and pass the tube normally?
You should start with the track. I have seen a couple people, once they're in there, they have pulled the tube out and done it, but I've never seen it. I've never tried it. You're more than welcome to try up here to put this in and go in blind. But I have seen some people, once they get in there, pull this out and then manipulate it from here.
Right.
But majority of the time, it's pretty much dead on once you get it. Once you can get the cords into the center of your view, all you have to do is push. And one thing I tell like new people is try to do it with one finger the first couple of times. Because a lot of people have a tendency, they'll get the right view and they'll try to advance it, but they'll grab the tube like this. And you're automatically pulling it out of the track. So it ends up popping out, or you start pushing it sideways. It literally, once you get the cords where you want them, all it takes is one finger to push straight down. And it goes right to where you want it to be. Any other questions before we try this out? No? Alright, I'm going to bring the mannequin over here and we'll have this practice. This is the only exception of the one that you can turn on. This is the trainer. We leave it in here, so on your shifts, especially until you use this a couple of times, each shift come in here and put a couple of tubes in just to get familiar with it. It's marked here that it's a demo, it's only for training purposes. This can be turned on and off infinite amount of times until the battery dies, so don't be afraid to use it.
Derek, is there a big improvement on this over, say, the glide scope or something, or is it just because this has the track that it's has a higher success rate?
That was a higher success rate than just a regular scope. It's very similar to the glide scope, to the King Vision. They're all just different brand names.
Okay.
We went with this simply cost factor. So.
Gotcha. Makes sense.
Oh yeah, it's lubed. Oh yeah. Have you used the glide scope before?
Yeah.
I'm not a huge fan of glide scope.
I'm not. I
couldn't get
can't.
the coordination down.
I can't get used to not. Your bougie's on the ground right there, by the way. But I can't get used to not looking this way.
My recommendation, if you're going to be using the glide scope, what I normally do is I either set it on their chest, or I have somebody, I'll have somebody hold it right there, so that it's the same orientation that you're used to.
Yeah.
That's the
I've
way I
tried. I've tried putting it like just above their head,
Yeah.
so at least then it's almost the same muscle. I've never thought about that. But yeah.
Or the other thing you can do if you're by yourself up there and there's nobody to hold it, just on their shoulders, you can set it between their neck and their shoulder right there. And again, that gives you pretty much the same orientation. Because I had the same difficulty when I first started using the glide scope. I had exactly the same issues.
Yeah.
It was like, the screen be over here and push it around. But then I just got somebody to hold it on the chest, or I'll set it again in the crease between the neck and the shoulder, so the orientation is the same.
Nice. All right.
So John just had a common problem. He went in and all you could see was the esophagus, which means that you're sitting way too low. So you try to pick up, and if you can't pick up enough, kind of work the machine back a little bit. It's the same with all the videos. You can either step your way in, or I go all the way in and step my way back. So you kind of go back and forth and pull it up a little bit. Try one with the bougie in it. Just see.
You just throw the bougie in this?
Yep, go ahead and
Okay.
load your track. Load your tube up. And then just put the bougie right in the tube, just so it's not hanging out
No.
at the bottom.
Like it.
Yeah. The same idea with the screen, or?
No, the screens in
It's a
hand
little tight in the center.
Okay.
Yeah.
adjust the screen
I think I've seen those then, yeah. Kind of like this one, it's just got.
for contrast.
Yeah.
flight program, we went from the Blackstone, we went from Blackstone to Pratt, A were smaller, and B, we carry out Blackstone parts, so we didn't have used it. Just the way the case was.
Here. So, well, I don't know yet on a person. I would have a name that would, like, literally in their mouth, right?
Any
Because you're
video in the scope, you
Yeah,
should be
you
suctioning before you even try.
Exactly, yeah.
It doesn't take much
Yeah.
to gump them out. This one, has not been too bad because the camera sits back up in there a little bit.
Yeah.
I've used the other ones
they're not
without the
the
fog.
camera.
You get it there and it fogs. It's
Yeah.
like,
Well, this has been pretty well. I intubated with GI bleed, and it just stuff coming up, and I saw it right through it.
It's, so I have
See,
had a few students
it's
that
hard
I've taught over the years
to do it on
that
a
have been
person.
left-handed, and it
It
takes
is,
a while.
and, you know, and a lot of people don't want to pull the trigger for that first time. It's hard to do that.
Right.
Been intubating
But
this
you have,
way for so
especially
long.
like people, I've been doing it for like 17 years, and I think it's harder for us
Yeah.
than it is for the new guys, you
That's one
know?
of the reasons I never
You're
went
like,
on.
I just is.
Yeah, oh, I don't know.
Yeah.
Just like using the Lurgus goes harder for me than it is for me. I've intubated one person before I Lurgus. That's it.
Serious?
Yeah, other than that, I use
Yeah, I would plug in the
videos.
Wow.
But if
so
I
it's the
put that
first
into
place
there,
that
it still
had
doesn't light up.
like, worked
Oh, I
with them
don't
for a
know a lot about these, but
I've used the
It's
glycoscope
recording.
on cadavers with Dr. Daly, but so what? You know?
This seems a lot easier, just make a little cut here.
That's the next thing.
Yeah, right.
with that.
I start breaking them.
I got all my units done this year,
Good.
but I didn't try to significant as I supposed to.
It's all kept online.
Oh, that's till it's solid, and then you can put this on?
Oh, you can put that on.
Okay.
Now it's solid. So it's like
So you're here for the MFI update?
Yeah.
I can give you a CME sheet if you need one.
Yeah.
Are you ever gonna have an actual like bowl for us? So I can push them?
Yeah, some point you will be.
Okay.
A lot of it is just participating, usually even the newer people that go through the process that they've never been
You see
involved
that?
with.
The cords in the middle or no?
Sort of like
Yeah.
Might be a little deep.
training part, and then of course as they do things and
Yeah.
move forward, then we, have Derek evaluate the charts and involvement, and then go from there. And
Yeah.
Yeah, it's way
It's been on.
I got Arthur too.
It's been on 3 and I
Oh, they're
I don't like that.
I'm right at the original,
Never
so
thought to
that's what I'm
sit down
trying
and
to get
study
up
it.
further, but.
That's the rocking things that go up there.
Yeah, I would definitely look over, I think
And
it's
then
gonna
come back.
change with the protocol, but
Oh,
look over the medications, get used to that kind of stuff, because if we don't have the ideal staff there
Yeah, I didn't
to
advance
do
the
it,
bougie
like
first
let's
and
say
that.
myself,
Yeah,
and
it's
Pat Lorenz.
It's just, just to
But I
get.
get it, like if you can't just get that,
Yeah, there's a lot of times where you push it and it just starts hitting the bottom.
Yeah.
You know, you're trying to
So
rotate
frustrating. That's how
and
you-
pull up harder
Yeah.
and it just, you can't get it in. So I put the bougie
yeah.
and it's literally just a spin to
Yeah.
get the tip of it heading the right way.
Mhm.
The airway. I get in there.
Well,
and
I
I'm
haven't so much
like,
trouble
compared to
with this
this,
there.
like when I was training.
Try it out.
Or put it in the tube first?
Yeah,
She was,
she was there you go.
fat. I know fat rolls actually in her neck.
Stop talking about me.
Like, this is not looking. Brandon actually got in there and I was explaining to him, he goes, yeah, you had it,
Put it in.
just, it didn't look right.
They're tricky at first. You know, pull straight toward your eyes until you get it right.
Is that the patient or the chair?
You have a good view, yeah.
I can make
Try
that
to
too.
at least
Yeah.
play with
Now
ball.
Well, that's a lot
Yeah.
easier.
The
Roll
right
to the
scope
side.
and the air track.
Mhm.
Hold it, yeah,
I
just
didn't
like
realize that that air track was a trainer.
Oh, you didn't?
No,
Oh,
What's that?
I didn't realize that one was a trainer, I thought it was actual,
Nobody couldn't just use it all
Yeah,
whenever,
yeah.
yeah.
cause I know 50 uses in that.
Yeah.
Yeah.
You haven't used it on a human agave?
That I have, yeah.
Oh, okay. How'd you like it?
Different.
Yeah. Did it work?
I got in there, I didn't recognize what I was looking at, but then I was talking to the person and I said, you try it, cause I looked once and spent like 30 seconds looking at it, like I didn't recognize it.
Yeah.
Had the other guy, Brandon, get in there.
Yeah,
Was the one that,
I got it now.
You're also
Was the
so
one you and
close
Doc
to
were
the
on. I
think I
cord,
was-
too. You know,
I had that
it's
idea
where it used to
of
be in-
you can't move it because
Yeah.
you're gonna
If this
click
is
the
the
teeth.
cord, it's right
But
there.
yeah, as soon as I
when
put a
you're
little
up
bit
like
of
this, you
pressure
got a
on
chance,
it.
like, okay, that's just
I'm in the
something,
right
there's a
spot.
cord.
Yeah.
You had that chance to say that, that's
So
what
I
you get.
can't see both of
Yeah.
that, that's
No.
interesting, yeah.
Oh.
That's another
Actually,
thing.
what I was taught with
Alrighty.
these, it's very hard to intubate the esophagus.
That's
So it
what-
turns on
Weights.
automatically when you
Yeah.
sit down?
Yeah,
Yeah.
there's a little pin in there on the
Got
side,
it, okay.
and it comes up.
I don't like to
What did
intubate here.
when you get in there and, what did BB used to say? Derek, what did BB used to say when you get in there? Clear the what? Garbage or? Yeah, cause you don't go in there with the tube first, you go in there with suction.
Yeah, yeah.
But, what's things?
Same shit. Different day.
But it's just another tool, and everybody has their own. I love these things, they bail me out doing this stuff.
No,
You guys doing blood
the one that I
okay?
was on, not too long ago, they had the video,
I don't know what the hell.
but you go in there blind, how do you?
I've tried the ones that don't have tracks.
And I'm looking at it, it was
See,
Phil
like
and
in
Doc,
Vision
and
that we had?
yeah, and I'm looking at it going, how do they, they're going in blind, how do they?
This is a blood product.
You wanna try and go in without the track?
Yeah, I'll give it a shot. Without style it, maybe challenge.
Is that gonna be a SCT thing here?
Yeah, that's an interesting idea. Is there room? We should find
Yeah.
out.
So what's the thing, is it just,
He's
you
got
just
it.
got EMS off from here, or?
No, I mean, I think a lot of it is going to be,
It was actually a really weird part, because he was in B-Phase.
This would be
We
good
were
for a
doing
clinic.
CT, yeah, we were doing CT.
you know, we're certainly not looking to take over
At one
Oh,
point,
I
he sat
see.
up,
sports.
and I was like, oh, we
A
got
lot
a
of the
reversal,
thing is,
we look, and he's still
you know,
in B-Phase, but then he
basically
kinda
just
went
doing,
back out.
Oh,
So it's really
you know,
weird.
frequently to call.
The
track
you know,
itself
like that
kinda gets
bird.
in the way.
Yeah.
Somebody was messing with you.
So,
So,
it was a weird,
we
but
put
he
it
was so
out there
clamped down,
and have,
Phil tried for a while,
the
and
availability
he
to
couldn't
do
even
it,
get his
so
mouth open.
theoretically.
So I switched to the airway, and I got his teeth open just
I don't wanna
Just
go
enough
crazy
to get
on
that
it.
in.
this,
See, that's
and then
something
he
to keep in
clamped,
mind.
clamped down on the track,
So we got the
like he
inserts
bit
in
the track,
pumps and
well,
everything,
like the
cheat sheets,
plastic,
everything else.
but I was already past it, it didn't matter, I could still slide the
Oh,
tube
that's
through the
Alright,
track.
I'll be right there.
So we ended up
And
intubating
then,
him while he was biting.
We got it
that's
on there.
interesting.
You didn't paralyze him?
Was it too
What's that?
crowded?
Paralyzed?
You want to
No.
go back to
Yeah, it was actually.
So,
When he pulled the track out though, didn't he bite down on the
What's
tube
that?
or no?
No, so he was biting down like here,
Yeah,
and the track's right through the center, so it slid right down through.
Yeah.
And I just kinda worked my way back out. He was still on B-Fit the whole time.
That is-
It was like 5 shots later before we found
States
out.
that we're able to carry any of those drugs.
I haven't been on a cold in a while.
So,
Oh, you wanna try?
just, doing all that kind of
I have trouble,
You'd be
A
surprised.
lot of it like this policy with this blood transfer.
You'd be surprised with this stuff.
Gave
Try
him
it.
a- a track.
You know, I know that it can
That's
be
fun. Make it fun.
CCT or a paramedic, but
Put around with
you
it.
know,
I
isolated
like
to
it.
Come on, Alex.
to do it.
Give you the chance to use it.
You wanna do it?
I've done it a couple times. I like it.
I'm not responsible if I kill the patient,
I think he's got
He's
this
dead.
chest.
You can't hurt him.
and I also need glasses to even see the scope.
You wanna go see any sheets, grab that. If you don't, just sign in, make sure you're gonna shoot, good to go.
Oh, I gotta do it this way, don't I?
That little one here.
You gotta pick straight up towards your face.
The glasses. I don't see anything except you.
I'll put it
Oh,
on.
I love it. This is
See
actually
if I can get it in a position.
I've been telling you for years, huh?
drives me nuts when I get a little bit of hair up there now.
Yeah, just a little bit.
Yeah, I did the same thing, I went in there and
I'll hold it for
it was
you.
too far.
Yeah.
Oh, okay.
I'll try to slide it straight down.
Take it off?
Yeah, yeah. Had to do the angle up.
No, there's two. Another one in Japan, like, they have one that has
annual updates
target
have
on
changed.
it. That's where the tube is gonna.
The annual
Because
updates sure
when
have
you're
changed.
looking at it, like,
It's going over to that
Annual
side.
updates.
you start pushing, you're like, whoa,
better?
Yeah.
the tube seems like it's coming right on the
You actually
side.
used to have 3 to 4 hour updates.
I was watching on YouTube, they got one.
I didn't know what to expect.
Or something, it's got a target on the end of it.
Poor motherfucker.
Oh, wait a minute. I didn't know it was in the right place.
There you go.
Yeah, I'm 5 minutes.
All right, Helen.
There you go.
Not too bad, huh?
I don't have it where it's supposed to go, the lungs aren't moving.
Well,
That's close.
that's
It's not
close
sealed,
enough.
it's not sealed.
Sorry, he died.
So if you want, I can show some of these guys. I do have videos of these done on live patients. I can show you after class. I don't have a way to
So
put them
much
up
for
here,
you,
but
less for me.
I can pull them
Wait,
up on the computer.
wait, can we
But thank you for
get to
letting me
them
try.
while we're working here? Are they gonna file? Oh,
No.
They
okay.
make an attachment for that, that's your smartphone.
So we have the attachment down there.
Oh.
The cords are activations.
Are you freaking kidding me?
Yeah.
It's
So-
all this technology, I'm too old for
Well,
that.
so you can buy, I mean, anybody can buy the camera one or the attachment to put it to your phone. It's like $30.
Oh my
Or
god.
download the app and it'll record right on your phone. Or we bought the actual camera, which was a waste. At the time, they didn't have the cell phone thing, so we spent $1,000
Oh
on the
my
actual
God.
camera. But we record them for training, so I do have.
All right, I'd like to see that, because it's different, because from
Definitely
doing
different.
intubations from far away, the cords, when they're like right here in your
Right.
face, and it is different, very different from that aspect for people who have been doing it with the, just laryngoscopy, you know, the old
So-
school kind of,
So this guy will be out here,
Your
really
range of
encourage you during your shifts
the
to
laryngeal things.
keep doing a couple twos each shift till you get real comfortable with it. You know, there's no policy here saying that you have to use it. You know, the places I work, they mandate video, we don't do that here. I just highly recommend that you do. Any questions on that part? You want to do documentation first, or you want to do hematology?
Go for it. Keep going.
And then when you actually do a blood smear, this is what you would see. All these little red circles are red blood cells. All right, you see they're nice and thick around the outside with a little bit of a pallor on the middle. That's a good looking red blood cell. So normal range for males 4.6 to 6.0, females slightly lower at 4.0 to 5.4. Every red blood cell contains hemoglobin. The hemoglobin is what oxygen binds to when it comes from the lungs. It binds to the hemoglobin, goes throughout your body, and when it reaches the tissues, it offloads the oxygen to the myoglobin in the tissues. It then therefore picks up the waste and CO2 and returns it to be excreted. So the purpose of a red blood cell is to deliver oxygen and remove the waste.
Okay.
I probably should have started, just so you guys know. It's before I got into my my EMS world. I actually went to school for clinical laboratory sciences. I did my bachelor's, and for about another 6 months, I have board certified for clinical labs, and I did hematology and blood banking. So it's been a little while. I'll try to answer questions that you have, but I refreshed the last couple of days, and hopefully I'll be able to help you guys out. So we just talked about hemoglobin. Two common values that we'll see on lab values that are very, very important, not only with the transfusions that we're doing during our care, but just in general, are hemoglobin and hematocrit. So we talked about the hemoglobin being the portion of the red blood cell that can actually carry the oxygen to the tissues. Normal range for a male, 14 to 18. Normal range for a female, 12 to 16. So if somebody has a lower hemoglobin, what is a big concern that we have for that patient?
Say that again?
If somebody has a low hemoglobin, what are we concerned for? What does that mean for the patient? What should we do?
Oxygen carrying capability?
Right, so they have low hemoglobin, they don't have they can't transport as much oxygen. So, and this is where you can actually see people that have sats at 99%, well, if they don't have any hemoglobin, the hemoglobin that they do is completely saturated, that's great, but they don't have a lot of hemoglobin, so they still could be forming hypoxia. So we want to make sure we're having adequate levels of hemoglobin and reviewing that. On these interfacility transfers, you're going to have lab values, and this is definitely something you need to be looking at. Hematocrit is the portion of red blood cells compared to the remainder of the blood volume. Alright, so typical for a male 40 to 54, and females 36 to 48%. So almost half of your blood volume, a little bit less than half, is red blood cells. I put there the rule of threes. Typically when you go to look at a lab value, you'll see the hemoglobin, you'll see the hematocrit. If you take their hemoglobin and times it by 3, it's generally what their hematocrit is. So it's usually 3 times what their hemoglobin is. If it's not, that means that there's most likely a fluid, because plasma is mostly fluid. It means there's a fluid shift. If it's a lot lower, then the patient's probably dehydrated. If the hematocrit is a lot higher than the red blood cells, then they could be overhydrated. But just in general, keep in mind that one level on the hemoglobin will raise your hematocrit 3%. And that'll come into play a little bit later on when we talk about transfusions. So red blood cell disorders. As you see, compared to the first slide, where when you look at a normal screen, usually when you do a blood smear, you see red blood cells all the way across, but not usually gaps. You'll see red blood cells throughout with white blood cells and other things sitting on top of them. You can see on the top, there's quite a bit of gaps. This is somebody who's anemic, low red blood cell count. All right, so you have all your anemias and a massive hemorrhage can result in low red blood cells. And then you have dysfunctional red blood cells. One of the most common that we hear about is sickle cell disease. And if you can see the little one, that's an actual blood smear and what they'll look like. They're also a little bit anemic, but you can see the kind of half moons. Those are sickle cells that you'll see on the blood smear. So if you take a cell that's kind of that half moon, you can see how there's not much hemoglobin on it. It really isn't able to bind any oxygen. So even though they have them, they're dysfunctional. They don't carry oxygen and carry out their job. White blood cells, normal range 4.5 to 11.5. So these are all the different, I've listed them there if you want to take a look, all the different types of white blood cells. When you get a white blood cell count, it accompanies all of this. Your most commons would be your neutrophils, and then it works its way down to it's neutrophils, then lymphocytes, monocytes, and then the eosinophils and basophils. You'll see they are present in a normal body, but when you start having higher percentages of those, it means that they're fighting some kind of specific disease. So your neutrophils are your typical bacterial and fungal. So the most common things we see, that's why there's normally more of those. And then when you get down to your eosinophils, they destroy parasites. So you see a whole bunch of those, that means there's a parasite infection. There's a couple little pictures of what they look like on a scan. So, as you can see up here, these two would both be elevated. Your top one has a lot of monocytes and a lot of lymphocytes. The monocytes are coming in to sweep out all the dead cells. So infection up here, and in the bottom, not quite as bad, but you can see a lot of lymphocytes, so some sort of bacterial infection. So when do we see elevated white blood cell counts? During infection, your white blood cells are produced in your bone marrow. So any kind of disease that affects the bone marrow, it can cause an overstimulation of white blood cells. Also autoimmune disease, so your body's targeting itself. It's constantly making white blood cells to attack your own cells. Decreased white blood cells, same again with the bone marrow. They're produced in the bone marrow, so if you have cancer in the bone marrow, it doesn't allow it to formulate or generate the proper cells to create white blood cells, that would decrease count. HIV, severe viral infections, and certain medications can also decrease the white blood cell count. So people with a decreased white blood cell count are obviously, like you all know, HIV patients are very susceptible to infections. Patients with cancer are going through chemotherapy. Those are the reasons. That kind of wipes out the white blood cell count, and they don't have the ability to fight off infections. Platelets, also called thrombocytes. If you look at the picture, you'll see just little clumps of dark purple throughout the screen. Those are your platelets. Platelets really have no form. They're parts of cytoplasm. They can be all different shapes, sizes. Well, they're all the same color, but so the platelets will come together with the coagulation factors that are in your plasma to form clots at an injury site. No picture on this one? Alright. Platelet disorder. So low platelet count, heavy alcohol consumption, viral infections, and leukemia. So patients with low platelet count are susceptible to bleeding. This is, most of the time we'll be dealing with patients, when we're doing transfusions, it'll be people with low platelet counts, and they'll be receiving platelets. High platelet counts, you would think of a massive hemorrhage, you would see low because you're using them up, but it's not true. When you have a massive hemorrhage or trauma or burns, you have a major injury to a site, your body's gonna kick it into overdrive and it's gonna start producing tons and tons and tons of platelets. So you're gonna see a lot of extra platelets on somebody who has a massive hemorrhage. The plasma, like I said before, is the most abundant part of your blood, makes up 55% of the whole blood. It's the liquid portion around all the cells that hold everything into suspension. You know, I can just send this to you later, you don't have to take a picture of it. So
Okay.
save you the trouble. And the plasma contains all the coagulation factors, and again, work with platelets to form clots in an injury site.
Ready?
So the components that we will be seeing for transport, whole blood, and we'll go through and break these down one by one after this. Whole blood, packed red blood cells, leukocyte reduced red blood cells, platelets, fresh frozen plasma or FFP, cryoprecipitate, and factors 8 and 9. I put this picture up just so you can have we're going to talk about labeling and patient identification in a little bit. That's a typical label that you'll see on a blood package. It's very important to, identification is the most important thing when doing transfusions. We'll get to that in a little bit. So, whole blood, exactly what it is. It contains everything. You draw blood out of somebody and it goes right into somebody else. Everything. It's not separated at all. This is really, you would think that this would be the most popular one, just give everybody whole blood, but really it's very seldom used. Most people require a certain component of blood. They don't require everything. So the whole blood is broken down and you can give certain components of it rather than giving everything to them. So it is an option, but not typically, you're not typically going to see this. Alright, packed red blood cells and leukocyte reduced red blood cells. Packed red blood cells are what we're going to see the majority of the time. This is your standard going in and getting a unit of blood. This is what you get, packed red blood cells. They do offer the option of leukocyte reduced, even when you're getting packed red blood cells. It's not completely all red blood cells. There are white blood cells in there. It has to be minimum, but they do get through. They're not completely washed out in the process. So for people who are prone to infections or immune reactions, they can get leukocyte reduced, which they're specially screened to really make sure that there are no white cell or limited white cells in there. Your typical packed red blood cells, when you hang a unit of packed red blood cells and you transfuse it, will increase your hemoglobin by 1. So if you have a 12.0 hemoglobin, you give a unit, it should increase it typically to 13. So if we're going to increase the hemoglobin by 1%, how much is the hematocrit going to go?
3.
3. Okay, so every unit, we're going to do 1 of hemoglobin and 3 of hematocrit is your general rule. All right, next.
You're saying that'll go by 1%, the hemoglobin.
Hemoglobin
Oh,
will
no,
go
the
up
hematocrit will
1.
be 1%, or 3%.
Yep,
So
hemoglobin
this
will
will
go
be
up by 1.
what, gram per deciliter?
1 gram per deciliter, and then hematocrit will go up 3% typically. Platelets, transfusing platelets, each unit is screened and they must contain 5.5 to 10 to the 10. That's a lot. It's a lot of platelets. So that's, to be a platelet donor or have a unit of platelets, that's the minimum requirements. When you put all those platelets in, a lot of them will get discarded and wasted, like typical platelets. So when you do give a unit of platelets, you should only see an increase of about 5 to 10,000 per microliter, which is still quite a bit. But when a typical person has, anywhere from 2 to 500,000 platelets, you can see how 10,000 not a whole lot. So. Next. Fresh frozen plasma. That's another very common one that you will see during transfusion. It contains all the coagulation factors. Cryoprecipitate is not a real common one. You most likely won't be seeing that during transfer. Mostly we're going to be dealing with packed red blood cells and FFP, fresh frozen plasma. During massive transfusions, you bring in a bad trauma and they're just massively transfusing this guy. After a few units of red blood cells, they're going to give a unit of fresh frozen plasma with it to to help out with the coagulation factors. Fresh frozen plasma is exactly like it says, it's frozen. Once they decide they're gonna give it, it takes 60 minutes or 40, depending on the facility, anywhere from 30 to 60 minutes. Most places are up to 60 minutes to thaw that out and have it ready for use. So it's not something that can be given right away. It takes some time, so that's why you usually get a few units of red blood cells before. So we may see this, but again, this will have to be thawed out before. We'll go over storage in a minute too.
And this is the one that you don't have to keep refrigerated for transport.
Yeah, I think that's on a couple.
The other thing you may see FFP for is, unless they're doing something different here, is to reverse an INR for head bleeds for folks that
Correct.
have intracranial pressure, which is that, and vitamin K. They'll give to reverse their INR.
There is, I believe there's storage on there, but just in case there's not, I'll cover it now. The storage units, if we get to it later, we'll skip over it. Your fresh frozen plasma, once it's thawed out, it's thawed. It doesn't get refrozen, it doesn't get refrigerated. So if we're transporting this, we will have the option of transporting additional units to be, if they have one running and the doctor says, oh, when that finishes, hang another, we'll be bringing those with us to start the transfusion. The fresh frozen plasma does not have to be refrigerated, does not have to be anything, it just sit out and be ready to use. Your red blood cells or your whole blood, that has to be refrigerated. So when we transport people and they want to send additional units, we'll be bringing a refrigerator or a small cooler from the blood bank with us to keep those cool. The red blood cells have to stay in the cooler until they're ready to be given. Alright, so transfusion of the red blood cells and fresh frozen plasma. I'll try not to go too crazy about this, but how do we select, what unit? We can't just take a unit out of somebody and give it to somebody else. It all has to be tested. So it's kind of a two-part for red blood cells and fresh frozen plasma. It's kind of a two-step process. Your platelets can be given. There's no antigens on there. They can be given to anybody. They're not patient-specific. So the first step in the two-step process is identifying the ABO system that you're all familiar with. I don't know over here, but you get to see my awesome drawing skills here. Is there a lock?
No. Want the lights?
Sure, for a second. So, you have A, B, and O. Here's your little cells. This is highly scientific, by the way. Here's your plasma around the cells. Alright, so on your type A patients, anybody who has type A blood, on your red blood cells, you have little A antigens all around it. Okay, that attach to the red blood cell. Floating out in your plasma, you're going to have antibodies and you're going to have anti-B. So those will look like little things like this. Like this. So you have anti-B floating around in your plasma and you have A antigens. Right, you can see how these wouldn't fit together. One's a square, one's a triangle. So they're happy, they're good like that. Same with B. Over here you have the B antigens. And in your plasma, you're going to have anti-A. So. Alright, and then AB, you'll have both of your antigens on the blood. Or on the red blood cell, sorry. And you'll have nothing in the plasma. Okay, this is why these are considered your universal recipients. They have no antibodies. What your antibodies are constantly looking for is antigens on cells to connect to them and destroy them. So your AB blood has no antibodies out there. It can receive any type of blood. Your O has no antigens per se on the red blood cell, but it has both anti-A and anti-B in the plasma. So this is why they're considered the universal donor. You can give this red blood cell to any other unit because there's no antigens on there, no other antibodies are going to react with it. However, O people cannot receive any of A. if you put an A or a B with these antigens, the antibodies in an O person will recognize them, attach to them, coagulate. So same with mixing these. If I were to give somebody who has A and they have these anti-B in their plasma, and I give them a B cell, these antibodies will match with the antigens will match with the antibody, they'll coagulate. So this is the very, very first step we look at. So we match up the patient's known ABO system to the donors to pick out the right AB. Alright, so that's where we start. There's also the other factor, RH factor, you all have heard. You're either positive or negative, so you're either A positive, A negative, for instance. That's the other thing we look at. If somebody who is has RH factor, so they're RH positive, say I'm O positive, I can receive either positive or negative blood. It doesn't matter. I already have the antigen. If you're a RH negative, so I'm O negative, you can only receive somebody who has RH positive once. The first time it'll be okay. You'll just create some antibodies for it, but the second time okay. So that's why we try to match up. You match up the ABL, you match up the RH factor, and that's where we start. So does that make sense? Or is there any question on that part of it? Good with that? So AB can go into their own, right? Or they can, either one can go into AB. O can give it to any of them, and can't take any of them. Has to take O. The next other thing, so that's our basic starting point. And then after that, once we select, so we have a patient who is A negative, we're going to select a unit of A negative, and then we're going to cross-match them, which is taking a sample of the patient's plasma and mixing it with the red blood cells of the patient, or taking a sample of the red blood cells we're going to give to the patient with the patient's plasma, and we'll spin them together and make sure they don't clot. The reason we do that is because there's hundreds of other antigens that can be on that red blood cell. The A, B, and O are the most common one, but there's hundreds and hundreds, and the more time people are transfused, the more antibodies they create, so it can react with certain ones. Next slide. So, there you go, cross-matching, takes the next one. Yeah, so we're not going to go through all of this is way too much, but the fact that I tried to show here is all these other antibodies that are up on the top here. So if we cross-match people's blood and we get a positive test, then you actually have to go through and figure out which antibodies and antigens they have in their blood, and you have to find a unit that's compatible with that. It's a nightmare, and you know it could take a while because you could have somebody who has 6 or 7 different antibodies, and you got to find blood that doesn't have any of those antigens. And then as soon as you transpose that, they're going to create them, so it gets even tougher every time you do it. So this is why cross-matching is still done. You typically don't just take a blood and give somebody else's A. You're still going to cross-match them and verify that it's going to work. And that's also important is you will see in the emergency department with major traumas or massive hemorrhages, they'll do what they consider an emergency order. And the doctor will say, we're going to give this patient, usually it's O negative, we're just going to give them O negative and hope for the best because they don't have time. Cross-matching takes time. So it's the best that they can do. They match up the ABO system, but they don't have time to cross-match. There's a lot higher risk when they do that. And that's why a physician has to sign off on it and say that basically the patient's going to die if he has to get this blood anyway. So it's the best that we can do. That comes into consideration when we're transporting these emergency orders. We need to be at an even higher level of alert for a possible reaction because it's more likely to have a reaction than a general transfusion. So, pre-transport actions. We're going to obtain the proper paperwork. Once we have the approval, we have all the paperwork in a binder for you guys to review. You'll get the proper orders from the physician, infusion rate, and how many units they want transferred, and make sure we have the appropriate units. You're also going to get a phone number for the doctor. It is in the REMAX protocol that if we're transporting blood, the sending physician has to be available by phone. In case anything goes wrong during transport, we have to call him directly. So that'll be on the order sheet. And whoever's sending it will have to provide a phone number. We'll obtain the blood administration sets because they're not typical normal blood set or drip set. And we'll get the baseline vitals. Baseline vitals is the baseline from when they started the transfusion. We need to record the vitals that they had when they started the transfusion so that we can trend those and look for possible reactions. Patient and unit identification. I showed you the picture before with the blood and it has the label on it. Once a label has been given to a patient and screened by the blood bank and available, that patient's name and label will go right on the bag. Alright, so it's very, very, very important that we're verifying that we have the right bag with us, that all the numbers on the blood match the patient's identification band on your wrist. Alright, and this will be signed off by both you and a hospital staff member, a nurse. It has to be signed off by 2 people that you're giving the right blood. Now, there's not a whole lot of things we do, but that'll kill people, but this is absolutely one of them. You give somebody the wrong blood, you'll kill them very quickly. So we need to make sure we're giving them the right ones. And again, must document if uncross-matched blood is being administered. If the doctor says they're not cross-matching it, that has to be documented. Blood administration, the high infection control standard. So one of the types of reactions that we'll talk about in a minute is bacterial contamination. It's probably one of the most common ones, and that's unfortunately this is the most avoidable one. Just setting up your drip sets with a good standard of care, a good clean surface you're working on, and Andre's going to go through when we're done here and show you how to set up the blood administration set. IVs must be 18 gauge or larger for blood for the REMAC protocol. It does say in children, it can be smaller at the discretion of the MD.
We have gone down to 20, size 20 in adults. I mean, that was changed like years ago
It
at
has,
Saratoga.
but according to the REMAC,
Right.
they want 18. So,
But I'm just saying, like, if we go to Glens Falls Hospital doing an interfacility and they've only got a 20 in that patient, I don't think I'd be starting another IV
I don't
personally.
think I wouldn't
Use
either,
it if they've been doing that.
I should put my REMAC stuff.
I know,
So,
I know, I get it.
only normal saline can be administered through that line of blood. Okay, no medication. If you have blood running, you cannot give any medication through that line with the blood. You can run normal saline through that same line. That's it. And patient education, you know, the risk, they've probably got that at the hospital. But the biggest thing I want you to remember is the symptoms. Talk to your patient. Let them know if they feel anything, if they start to feel funny, let them, make sure they know to tell you. You know, any kind of symptoms start, make sure they're gonna tell you, educate them, so that we can, you know, treat it before it gets worse.
Of course, you got the unconscious vented patient that's not talking.
That's fine.
Just make sure you monitor for that stuff.
Monitor.
What I've personally seen is that a lot of patients that are having some kind of reaction are typically presenting with back pain. And that's one of the biggest flags for us. And it sounds stupid, but I've seen that a lot when when we're talking about reactions within the hospital. So if somebody starts complaining of back pain, you should certainly be, having your radars up and, paying attention to that, because it certainly could be. And that's one of the things we'll talk about,
Alright, so here's a list of all the reactions. I'm not gonna read them because we're gonna go through one at a time real quick. Go to the next one. So a hemolytic reaction. An acute hemolytic reaction can be instantly. It could be delayed up to a couple of hours. And a delayed reaction is, over a couple hours, and that usually starts from somebody who's been transfused before. A hemolytic reaction is basically when your red blood cells are entered into the body, and that patient has antibodies for those, and they come together, they clot, and then you have a hemolytic reaction. So this is probably one of the most serious ones, but the most avoidable by cross-matching. Signs and symptoms are where everything has a fever. Any type of reaction, you're going to see a fever. That's a good telltale sign of reaction. They're going to start wasting the red blood cells that are being destroyed. You're going to start seeing inuria and hypotension, because all those red blood cells are now dead and they're being removed. So you're actually making the patient more hypovolemic while transferring. Transfusion-related acute lung injury. This is a form of non-cardiogenic pulmonary edema. This is when your leukocytes react with the leukocytes that are in the blood cells. That's why people who are at a high risk for reacting like this will get the reduced leukocyte red blood cells, but if there are still white blood cells in there, they can react. So basically it forms a little emboli in your lung, and it will act basically like pulmonary edema, sort of, with a little emboli settling in the base of your lung. So the common signs and symptoms are cough, fever, cyanosis from poor perfusion, and again hypotension. So we're getting the red blood cells, same with the last one, the red blood cells are getting destroyed and wasted, so even though you're putting red blood cells in, you are becoming more hypovolemic. Transfusion associated circulatory, top of our level. This is basically causing CHF by administering. It's typically done by administering blood too fast. You simply just overload the system and you start developing backup of flow and congestive heart failure. So your signs and symptoms are exactly the same as patients who are in CHF. Coughing, orthopnea, trouble breathing, chest discomfort, restlessness, anxiety, all that good stuff that comes with CHF. Typically this can be reduced, or the risk can be reduced by controlling the flow and not using too high of a flow rate. So how do we monitor for reactions? Vital signs should be obtained at least every 15 minutes. That's the absolute most on these transfers, every 15 minutes. That includes your standard vital signs and a temperature. Temperatures need to be checked on these patients every 15 minutes so we can look for trends. And again, we've already obtained the baseline temperature and vital signs from the nurse, and we need to monitor for any changes.
For some reason, I thought it was every 10 minutes.
No, it's 15.
Another DOH forms.
I pulled that from the form. Monitor lung sounds, looking for the circulatory overload. Physical exams, looking for urticaria, rashes, any warmth on the skin, and verifying that the patient has no complaints. The patient should be able to give you some early warning signs usually. So
10 minutes.
good, I like that better, but it's on the sheet you sent me. I'll pull it up and show
No,
you.
I believe you. I remember seeing it there. That's why
I
when
like
we
10
talk
minutes
about
better
the
anyway,
protocols, it'll be.
Alright, so vital signs every 10 minutes. Be sure to change that on there, I apologize.
But
Yep. So, what do we do if a reaction occurs? First off, stop the transfusion immediately. Disconnect it, maintain the line with IV normal saline, 0.9%. Keep the line open, and contact the medical control. The medical control being the physician that sent the blood. Like I said before, we have to have a phone number that we can reach that physician if we're transferring. So you're going to call the physician, advise him of the reaction, and obtain orders for what he wants to be done next. Once you get to the destination, all of your blood supplies will be turned over to the receiving facility. That includes unused bags. You know, if they send you with 3 units and you only use 2, you're going to turn all of that stuff over to the receiving unit or the receiving facility. They'll take it to their blood bank and they'll waste it appropriately. That's all your slips, tags, labels, everything that comes on there needs to be turned over, and the administration sets. So once we take this, we don't bring anything back with us.
and that includes their container.
What's that?
Their like refrigeration unit type thing.
Yeah.
Whatever that is up there as well.
Everything, yep. That was a reference. Any questions?
Can we talk a little bit?
What's that?
Can we talk a little bit?
Yeah, you want to do the...
All right, so just a couple things in regards to this. As Derek was saying, that there's an actual blood transfusion record that will be sent, and this is what you're going to be using for verification. So this is DOH forms, is the blood transfusion transfer orders, which you'll be reviewing as written by the physician there at the facility, and then this is the transfer record. With that, there's an actual flow sheet here in regards to blood products. Moreau EMS person or critical care technician or EMTP, which obviously is going to be critical care, a paramedic, currently online in the Remo region, has completed the agency-specific interfacility transport training on blood products, may initiate, administer, and monitor transfusions and provide interfacility transport care without a nurse for a patient who is in need and has specific interfacility transfer orders for such. So upon determining that a patient will be transported with blood or blood products, the paramedic shall review the blood transfusion transfer orders as written by the ordering physician and on the approved New York State DOH Blood and Tissue Resources Program form. The form shall be completely filled out, reviewed for accuracy, discrepancies, and signed by the ordering physician. That's the actual transfer orders. So this says the patient's name, date of birth, ID, date, transferring hospital, receiving hospital name. Do they want you to continue, pack cells, other, at so many mLs per hour. Also administer packed RBCs or other, how many units, what's the rate per ml per hour. Special instructions, ordering physician's signature, printed name, phone number, and then below to be completed by the ambulance transfusion service personnel. What's the ambulance service name? What's your New York State EMT ID number, print your name, PCR number, and any kind of remarks. So this stuff should be, when you're getting to the receiving facility, you should definitely have a copy of this for your chart. That'll be an important thing so that you have reference. You know, you always want to go back, same thing with our transfer orders. When we're talking about those things, you always want to have those to reference, even though you're going to be delivering that to the hospital with the patient. Specifically, if something comes up, then they, challenge, well, I never wrote that order or whatever else. At least you have some kind of documentation that's attached to your chart, which will be important. The blood transfusion record, this should be done at the bedside. Patient's name, date of birth, all that stuff should be filled out. Transferring hospital, receiving hospital name. So the pre-transport identification, this is going to be done with an MD or an RN. Patient wristband ID compared with all blood product components. Units at the patient's bedside with hospital staff. Products are packed in a validated transport container with a pre-transfusion blood specimen if available. Sometimes they'll actually send like a tube of blood with that in that cooler, is what this is saying. Number and type of components agrees with physician orders, and the patient has a dedicated venous access line with only blood and or normal saline running through it. And then it says components transfused. You're going to write down the component, pack cells, what the unit ID number is, unit ABO, RH, start time, date and time, end date and time. Was there an adverse reaction, yes or no? And then down below here it'll say, if there's no reaction, discard the empty blood bags and use administration sets as medical waste. Give the following to the receiving hospital at the blood bank. Transport container, the manifest packing slip, the unused blood components, copy of the blood transfusion record, and the blood specimen if there's one in that container. Like they might want to send a little bit of a sample of blood for that receiving facility. If there is a suspected reaction, then you're going to check yes, and then you're still going to give everything over to that hospital, including that tubing and the blood bag that you stopped. So that should be all transferred over to them as well. And this is all outlined specifically in this policy here. In transport, as Derek said, temperature, pulse, respirations, blood pressure. Temperature is important because obviously we might see a reaction with the patient developing a fever. Should be monitored every 10 minutes, recorded accordingly on the chart, which Glenn will talk about in regards to documentation. Some clinical conditions may indicate a need for more frequent monitoring. All vitals should be compared with the previous values. So if all of a sudden you got a blood pressure of 70 on 30 and they've been running around 120 on 80, then obviously there's a reason for concern there. Ambulance crew must be present at all times during a transfusion and for 30 minutes afterward. And theoretically, when we deliver to the hospital, they're saying that we should be hanging around that facility for a good half hour in case there is questions in regards to transfusion. But in theory, after we've delivered a patient there, usually we're in that area anyways for about a half an hour. And once you've put your ambulance back together and your unit, you're ready to go. But I think it's just as a mere being available for questions in regards to the transport if necessary as it relates specifically to blood and blood products. The transfusion rate of flow shall be observed and regulated according to the physician orders. During the entire transfusion, the patient should be continuously observed for signs and symptoms of a transfusion reaction to include, but not limited to, feeling of impending doom, fever, chills, constricting pain in the chest, shortness of breath, back pain, shortness of breath again, tachycardia, hypotension, bronchospasm, laryngeal edema, a rash, and unconsciousness. Please reference transfusion reaction protocol below. All medications, equipment, and supplies necessary for management of adverse reactions shall be immediately available. Meaning what we carry in our ambulance, and we should have that available for the patient. Be intubated, blah, blah, blah. Transfusion reaction guidelines. Immediate reactions include, for acute hemolytic transfusion reactions, bacterial contamination, all the ones that he talked about, so forth. Specifically monitor for above noted signs and symptoms. Discontinue the administration of blood. Immediately stop the transfusion. Keep the line open with saline. You're not going to keep the Y tubing that's hung. You're going to basically take all this down, put it into a red bag with the blood, and then you're going to start a new line of saline and just run continuously through that line. Treat per protocol, alert medical control as soon as possible. Additional interventions therapy as ordered by medical control physician. Do not discard of the blood, bags, or administration set as must be given to the receiving hospital staff. Do not initiate another unit unless advised to do so by medical control physician. Upon transfer at the hospital, you're going to give them the New York State blood transfusion record shall be completed. And that is the bottom part of this is you've transferred the patient, was there a transfusion reaction suspected or not, and then the receiving hospital needs to sign off on it. So you're going to get signed off at the sending facility, signed off at the receiving facility, and have that form filled out. And of course, if you're leaving that, make sure you have a copy for your record. All this stuff can be reviewed here as we put this stuff together. I know this is a lot of information, but it's just, this will be available. This binder, not the specific one, but a binder like this will be available for your transport. So when you go there and you're doing blood products, you can use this as a flow and a guidance in regards to what needs to be done. In the event of an adverse reaction, the MES medical director is required to submit a report to the DOH within 24 hours. There will be 100% quality assurance review by the medical director for all patients transported with blood products. And I think what we're going to do with that in order to be compliant is sort of like what we do with the controlled substances. Once a controlled substance is administered, we have to print out the chart and attach that for Dr. Jagoda to review all the controlled substance administration. Same thing will be with here. If you do a transfusion record, transfusion orders, and for some reason if there's not controlled substances administered, then I would still print out the chart and have this as another packet for Dr. Jagoda to review, and we can show that we've had full review of each of these charts. All right? And there will be yearly mandatory blood products transfusion training for all providers credentialed in interfacility transport involving transfusions, and of course we'll have that and we'll incorporate that into our RSI training so that everybody can remain abreast and up to date with that kind of stuff. All right, in regards to blood transfusion. The thing is with blood transfusions is that this is used with a Y tubing, and sometimes it'll be run through a pump, but what I've seen like back in the day, obviously we always had non-pumped tubing, which is this what we call Y tubing. So one goes to your normal saline, one goes to your blood product, okay, whether it's fresh frozen plasma or whether it's packed cells or what have you. Then you have your chamber, almost looks like a burette, all right? So there's like a filter in here. And the biggest thing is that they don't, the way that this filter is, it doesn't allow for it, but they never wanted the actual drop to fall onto the filter because they thought that it would, affect the red blood cell and break it down. So you always want your fluid above this level so that it's dripping into water, basically, okay? And then you're going to bleed the rest of your tubing down, and then this is going to be hooked up to your patient. So what I do with all this is I clamp down all these tubings. You have a dedicated set of tubings for every packed cell. So if you are hanging a second bag of packed cells on your way down, you'll have another set of Y tubing to be done during the transport. You don't want to sit here and reuse that. That's what I understood. Is that correct? Yes. Okay. Typically, the bag of blood looks like this. I mean, obviously, it's like Derek showed in his picture. It's red. It looks like blood and so forth. But there's some kind of tag system that's put here, not the pump tubing that I have on here. But these tags have all the information as it relates to the patient, like their HO number, their XO number, the patient's name, their date of birth, what type of blood products and so forth, which matches this, which matches this, which matches their ID tag. So when you're comparing these things, you have one person at the bag comparing all this, and then you're verifying these tags to their ID band. So when you guys are doing bedside verification, somebody should be looking at the patient's ID band. You should be verifying this with either a nurse or a doctor and just comparing stuff to make sure that what's hanging here actually belongs to John Doe. All right? So a new set of tubing, you're ready to go, hanging a new bag. This has been pulled out of your cooler. This has all been verified before you've left, so you know that this is ready to go. You're ready to hang your next set. You're going to have a bag of saline. So, I mean, obviously we carry a 1,000 cc bag of saline, and that's fine to use. It's not like you're going to be using a lot of this anyways. So you want to maintain utmost sterility. Of course, you don't want to sit here and rub all this stuff and whatever else. This is no different than starting an IV bag. I've clamped all these tubings down, right? This is sort of upside down if you realize the roller clamp goes this way. But I still lock all these up, all right? So the first thing I do is I hang this here, and then I open up this clamp here, and then I open up this clamp here, because opening up this clamp will bring out saline over here, right? Because we don't want this full of air. Does that make sense? Because if I just plug this into the blood, you're going to basically put this much air into this area here, which you obviously don't want to do. So by opening this clamp, it's shooting the water out of here, the saline. All right? Next thing I do is I go back and opening up this clamp, and then I fill up my chamber. Well, I guess it's not going to let me do this. This used to be a more pliable thing. I'm not really familiar with this. Oh wait, maybe, no. All right, I guess this is not allowing you to do this. Back in the day, this used to be where we could prime it like we could regular tubing. Oh, there it is. I guess the top part of it is. You hold this.
Yep.
The thing is that this tubing looks a lot different, this filter I should say, because now it's just dripping into the center of it, and it's not actually dripping onto a filter the way it used to be. So I'm assuming that this has been changed. Well, now I'm able to do it here. All right, so I'm filling this up. There, you got to do the top part, the bottom part you can't do it because of the filter. See how the water's, the saline's there? Now at that point, this clamp is still open, and now I'm going to prime my rest of my tubing. All right, so we'll say that this is completely primed. All right, close this clamp, close this clamp. We don't need the saline to run while we're running the blood product. All right, this has been primed, this tubing's primed. Now we can take our bag of blood, do the set. This is still clamped, again sterile. Spike this. And if you think this is bad, you should see doing it on a blood bag because it's like two little things that you pull apart to open up the reservoir, the spike port. All right, so this is closed. So realistically, that could even drop down. But anyways, you're going to open this up here, and then you're going to open it up here, and then you're just going to infuse it. See it dripping down? So now you're just going to infuse the blood product, and you're going to be monitoring it here for infusion. So obviously, if you're doing it at 100 mLs per hour, this is going too fast. And of course, they could have it on a pump. So just see what kind of tubing they have in regards to that. I think their tubing would still look like this going through a pump, because when we learn the pumps that they don't have, like Saratoga Hospital has like a little thing that goes into a pump, and there's like a little discus here and so forth. That's not the way the Glens Falls Hospital pumps are. They actually go through here. So they just put this into there, put this into there, into the pump, set your flow rate, and it's actually run through the pump that way. So that's probably why this tubing looks like this. But you're still going to have to prime all your tubing, just like I did before putting it into the machine, because otherwise they're going to have that problem like that Baxter rep was talking about, that you would have air into the system, and then you're going to have a problem with air in the line. Make sense? All right, you guys can play around with this stuff if you want to in regards to tubing. I'm just going to clamp this off. And then when you're all done with this, just remember all this goes back to the hospital. Ultimately, this can go in the garbage once it's empty. This tubing, all this tubing and so forth can go into a red bag, provided there's been no reaction. This would come off, and this would be signed off, and you transfer that over to the receiving hospital, and all that should go down the blood bank. And they should have, you know, we're going to have a contract with the hospital which specifically states that process and how they're, you know, we're responsible to hand it over to that. Even if you go with a cooler with the extra pack cells, all that stays there at Albany Med. Okay? All right. Anything else in regards to blood? The only thing I have to do is we have this objective competencies in regards to blood transfusions and so forth, which we can sign off in regards to doing this and having the hands-on, but a lot of it is just making sure that you're monitoring for reactions in your patients, you know, fever, shortness of breath, chest pain, back pain, and then of course all the normal adverse reactions to any kind of medications you want to be concerned about. And then, of course, treating that accordingly. And you should be online with medical control. If there's a problem in regards to a patient's transfusion on the way down, don't hesitate to call If you're able to make contact with the sending facility, I would certainly talk to that facility. If you can't, you always have the place that you're transferring that patient to, and talking to them in regards to that.
Where in the back do you find that they were complaining the most, like upper, lower?
Lower back.
Lower back?
Yep. All right. Any questions in regards to blood? All right.
You
No?
think that's because of the kidneys, Barbara?
Yeah, I think so. I think that's what I've generally found is that.
Coagulation going on in the
Yeah.
kidneys, filter.
What about you? Have you heard anything with that?
I've never given one.
Oh, I didn't know if you had heard in regards to transfusion reactions, but it's just very weird. Like I found that they just had like lower back pain, almost like a UTI type symptom. That, you know, and that's why it's important to relay to them that if they experience any kind of different type of sensations, you know, I'm not just saying like back pain, but you know, if things just don't feel right and things are, you know, could be arm numbness or could be something different. I mean, those are things that they should be relaying to you, and you should assess accordingly. Reassess vitals, document that stuff, and I think a lot of this with blood transfusion, not that we have specific drop downs for that, but in your documentation, as Glenn's going to talk about, with blood, I would specifically be documenting the blood product number and what the what the blood is, the component, and the type of blood product that you're transfusing. And then as you're making an entry, I would specifically document the patient's any complaints or any kind of non-complaints, and that, you know, it's infusing without issue, and then make sure that you do your vital signs and including your temperature in that. Because those are things that you're going to look at. Like when, you know, let's say Derek's going to review these charts, or Dr. Jagoda's going to review these charts, and we're trying to determine if the patient's having a reaction or not, or if there's some kind of problem during transport. We're going to look for a full set of vitals, and that includes that, you know, that temperature. All right. Why don't we take a couple of minute break? There's some pizza out there. Let's get something to eat. I don't know. Check yes or no as it pertains. I would hope that it's all yes.
So if you wanna turn around anytime you can.
And then I'll sign off on this stuff. I'll have you sign off on that. All right, so Glenn's going to talk about documentation, not as it relates specifically to transfusions, but you don't need this one.
No.
But as it relates to specialty care transport.
I'm just creating a blank chart here real quick, just to have something to work with. I'm just getting it in there.
Pretty cool.
Okay, this is gonna be a little weird, folks, just because I'm gonna be working on the computer at the same time that I'm trying to talk, so if you can't hear me, let me know. Andre asked me to do something just on documentation for specialty care transport yesterday. So basically, you know, I told him I wasn't gonna put a lecture together, just didn't have time, but I would go through EMS charts and kind of give you the pearls and the training that I've had as far as what to document with specialty care transport. So starting with the dispatch page, obviously, this is all stuff you guys already know, your run number, your yearly run number, your REMAC number, all that stuff. Really important here under times, your at-patient time is very, very important. When they start looking at specialty care transports, they start looking at bedside times. And I would imagine at some point he's going to want to track those. When we start having super long bedside times, you know, there really needs to be a reason why that's going on. Part of our job in specialty care transport, the reason why they're leaving a hospital like Glens Falls Hospital, which for all intents and purposes does a really good job, and there's a lot that they can do there. So the stuff that they're generally shipping out by specialty care is sick stuff that needs to go now, and it needs to get to a facility where they can do a procedure or an intervention that can't be done there. So it's usually a time-sensitive or life-saving intervention that can't be done there. So bedside time is important. Do make sure that you document that. Andre, you may want to consider at some point adding leave bedside as well. And I know that's something that can be added to the time list. That way you can truly look at bedside time versus the amount of time, say, it took to get out of the
What is it
hospital.
called?
Leave bedside.
So when you're leaving,
So,
at patient, leaving bedside, and
Right.
then leave referring.
correct, so you're at patient, or it might be leave patient, but, it's either leave bedside or leave patient, it might be leave patient. But then you can actually look at the true bedside time and how much time it took to package the patient and get them out of there. And then you can start looking at trends too, if it's something that your ICU trips, you know, take 50 minutes at the bedside, is that a facility problem or is that an us problem? Is it we don't know the equipment well enough, so it's taking us forever to manage these patients and to get them switched over and ready to go out the door, or is it a facility problem? We're getting there, the paperwork isn't ready, the staff isn't trained how to interact with us, and really you can track those times and cut down on a lot, but adding leave patient, I think is what it's actually called, would give you the ability to look at actual bedside times. But certainly document them, and at bedside is at patient is currently available. So, I'm sorry.
No, just talking to
So we did look under patient category, maybe it was response. So we did look at it under response, and there is specialty care transport tags in there. Priority 1 specialty care transport, as you can see, or there is priority 2 specialty care transport as well. So those are available for selection. Obviously, we're going to change this from a scene to an inter-hospital, and there is no specialty care there. So again, it's under response, so we would just change that to inter-facility. Most of your specialty care transports, I would argue, probably are going to be unscheduled. I think it's rare that we'll do an SCT that is scheduled. Patient category always remains the same, so this one we're just going to call it chest pain.
Or there is an inter-facility down below too.
So outcome is going to be treated and transported, right? Do you do ALS? Is that what you put in
Yeah.
there?
Yeah, we probably can add treat and transport to SCT.
I would think, yep. I would probably think that would be good. All right. Code, you're going to call this a transfer trip. And then your vehicle grid, as Andre and I just discussed, that is where the vehicle initially responded from. So here we'll say it's Moreau. So over here, this was tagged initially as an EMS response. We're going to switch that over to hospital. I would imagine Glens Falls is in the pick list. You got to drill it down a little bit. See if that'll do it.
For the percentage sign.
Percentage signs, yeah. So the next go-to. Did everybody copy that? One in front, one in back. That opens up your search grid. Hopefully that will do it. Yep, there it is. Okay, so in this particular one, we'll call it from the emergency department. All right. Referring doctor is Tom still there?
Yep. H-A-H-M. H-A-H-M.
Alright, so, scene grid, that's where it's coming from, Glens Falls Hospital. Alright, and RFT,
Reason for transport.
okay. So, you freehanded that, Andre?
Yep.
Okay, so, I don't know, cath lab not available. I would not, what I found in the past, people, we used to have a drop-down menu for that at my previous job, and people would always select EMTALA certified. The insurance companies hate that. They actually want to see a reason that the patient is being transported from the facility for something that could not be provided there. That's what they're looking for. So just EMTALA certified was kind of like your last choice if you had nothing else to put. So I would actually put a reason in there, just not EMTALA certified. Receiving hospital, obviously very, very easy. I'm going to use the percentage signs ahead of time here.
Spelled Albany wrong.
There we go. It's because I've been gone so long. Don't know how to spell Albany anymore. I can spell Anchorage. So we'll call it Albany Medical Center. Great. So lights and siren, that's obviously whatever mode you're going to be going by. So your destination bias is a pick list here, and generally you're going to be selecting Specialty Resource Center. Now, if you start getting into stuff like, and you can click more than one, the other one is closest facility you'll sometimes hit, because that takes out the question as to your ABN, and why did this patient go, to, if the procedure could be done, I don't know, in Ellis, and Ellis is actually closer, why was it not done there? That question may come up, so if it is the closest facility, checking that also helps. One of the last things you want to hit, certainly without an ABN, is patient choice. Okay? So we'll hit that for closest facility and specialty resource center. Destination grid, obviously that's where you're headed to. And then any comments you want to put in there. Any particular things, Andre, you would put in there?
No, I don't. I think that's just a box that's typically there, but I've never written anything in there.
You could probably say like their room number or something like that if you wanted to,
Yeah.
but not a big deal.
If you're going to like, CCU bed 10, sure.
You know what may not be a bad thing to put in there either is who you turn the patient over to. Patient turned over to, Brenda Smith RN or
That's a good point.
Dr. Ron or whatever the case may be. So who you turn the patient over to may not be a bad idea either.
Technologist claim.
Don't
Yeah.
forget with your odometer, with Medicare and the insurance companies, you have to use tenths. So 125.1 and let's just say 175.3.
You should really be having a tenth of a thing too, like, I see a lot of charts where people write 125.0 to 130.0. And that's because there's not a tenth of a mile on the odometer on some of the ambulances. So you gotta think that if Medicare is ever gonna come in and review our charts and do an audit here, these are things that they're gonna specifically look for. And they're gonna literally pull up like Google Maps. I mean, Myra will tell you, like, they'll literally pull up these things from her conferences that she learned, just to, as stupid as it sounds, just to find out and make sure that we're putting in proper documentation. And that's why it's also important that if you have to detour when you're going down there, let's say point A to point B, Albany Med, it says 52.7 miles. And you've got documented 67.5 miles, but it's because you had to go a roundabout way because of detour. That's an important thing to include in your chart on why there's such a discrepancy in your mileage. Don't just document it assuming that we know why that's going on. But use that tenth of a mile, and if you don't have the exact tenth of a mile, you could certainly start at 152.0, but again, if you use like Google Maps or MapQuest or any of those things that gives you those tenths of a mile, that would help too with your documentation.
Hit the trip reset too on
And
the
the trip rate.
Teleplex.
Even without the trip reset, if your mileage is on your odometer is 1, 2, 3, 4, 5, if you look down at your trip underneath your A or B, it might be 350.2. So you can put 123.12345.2. And then when you end, again, even if you don't reset it, you could put in
Yeah.
12375.5, just using that trip set on the bottom.
But the only problem with that is you can skew it a mile. We went through this with the Mercedes, So if your trip, it has like your mileage on top has an intrinsic decimal point really. You can't see it, but it's there. So if you're at 0.5 on your trip and you go 0.2 miles down the road, and it changes it can charge you for 1.2. So the only way to really do it is reset the trip.
Okay. Okay, good to know.
6, right on that.
No, it's cut her off.
Yeah, thanks.
I can go. I'll go.
Okay,
Andrew, I don't mind going.
so obviously with the patient information, getting as much as possible is important. Fortunately, with our specialty care transports, we're generally gonna have a face sheet. And even if they don't know who the patient is and they have it listed as an alias, the medical record number is there. So eventually that patient's gonna be identified and we'll be able to bill through that medical record number through information sharing with the hospital. I don't ever bother with this immunizations, employer, physicians, email stuff here on the bottom. Barriers to care, if there is a significant barrier to care, like language or whatever, I'll put in there. But really immunizations, employer, physicians, email, I don't know anybody who enters any of that.
Where do you put their primary care physician then?
I
Or are
generally-
you talking about just SCT?
SCT.
Oh, okay. All right. I'm sorry.
I generally don't. All right, so we got our billing information, whether or not they got their privacy forms. whether they signed the consent form, the PCS, whether that was signed or not, which of course these all should be yes. And even if you are signing in section 3 of the consent, because they're incapable of consenting because they're unconscious or whatever the case may be, the consent is still signed, it's just signed under section 3. So you're gonna answer that yes. Because again, it is still paid. Andre, you ever used the prior authorization payer? No, I didn't figure so.
And I only use the consent form and the PCS form on interfacility transports, or coming out of, like, if I'm doing like a transport back to Home of the Good Shepherd, I'll fill out the consent and the PCS. The NPP, the Notice of Privacy Practices form, that should be changed on every patient encounter, whether it's a transport or whether it's a even a scene transport to the hospital.
Because you're attaching copies of the face sheet, Andre, are you guys entering billing information?
I typically do, and I don't usually attach it. What I do is I personally will throw it on Myra's desk or have people throw it into the run sheet box, but I'll just manually enter in their insurance info.
All right, there we go. So reason for transport, there's a pick list here that you can pick to, and again, patient was transported for care of a specialist or for availability of equipment is generally what we're picking when it comes to SCT transports. The date was signed, I mean, all this is very self-explanatory. So where it gets a little crazy, again, down here, this mileage to closest hospital, if you get into a situation where there is a hospital that's capable of providing that same service, that's when you get into the whole ABN thing. And that was big for us in Alaska because we used to get called all the time to take people to Seattle when Anchorage was 700 miles closer. Well, at, $125 a loaded mile in a jet, that gets real expensive. So, here, okay, you might be talking St. Peter's is a mile and a half closer or whatever than Albany Med. I guess you're kind of splitting hairs, but are you? I mean, if you ever audited, that it could be questionable. So if they're going, and Andre, again, I don't know how you guys are running things, so that's why I'm kind of deferring to you a little bit. But if you're going to a facility that's further away, simply for the reason that that's the referral pattern, you need to document it. It sucks, but you need to document it. You really should be getting an ABN signed as well to cover the billing. Do you see what I'm saying?
People take
What's an ABN? I'm not.
assignment of benefits.
Okay, I don't know this
Well,
side of.
we'll do those on the transports, and when they talk about ABNs too, it's specifically as it relates to Medicare. So like there's two forms hanging in the radio or in the boardroom as it relates to transports. The PCS is the physician certification statement,
Right.
and that has to be completely filled out. It also has to be specifically with Moreau letterhead, not letterhead, but it has to say Moreau EMS at the top, not Empire Ambulance.
Yeah.
And then there's section 1, 2, 3, and 4, and all those sections need to be completed. A lot of times when I get handed these sheets, these PCSs, even going back to Home of the Good Shepherd, it's incomplete. And you're hard pressed for a document, and it's not for us to fill in by any means.
Right.
In fact, we shouldn't be filling it in.
And that form can be filled out by a nurse, a discharge planner, a physician, a PA, whoever, and it's all these boxes at the bottom, it basically says who can fill out this sheet. So if I get that form and it's not properly filled out, I hand it back to them and say it needs to be properly filled out. Not everybody does that. Usually we'll get that form handed in at the squad. Myra will be looking at this and being like, this is, there's literally like one checkbox here and, questions 2, 3, and 4 isn't filled out. We've got to make sure that those things are properly filled out. The ABN is related to Medicare. And it's like option 1, 2, and 3. Option 1 is like, yes, I want you to bill my insurance for that. And the patient's the one that ends up signing that. So usually they want us to bill their insurance, check off ABN, option 1, they sign the bottom, they sign our computer, and we're all set to go.
Right.
We tell you to have that ABN signed on all patients because it's not for you to determine whether they have Medicare or whether they don't, or whether they're active or whether they're not active. It's just easier to say, have everybody sign it. If it's needed, great, it's filled out.
And here's the other issue, and correct me if I'm wrong with the way your ABNs work, but the other thing with the ABN, it should state in there that if you're not being transported to the closest or nearest appropriate facility, that you could be responsible for the excess mileage that's incurred.
So how do we deal with that?
You explain it and have them sign it. That's the way,
This, the
companies I
sending
was with.
facility.
Yeah, and that's all on that form.
Okay.
And, they should be reading that stuff, but how many patients just are like, yeah, I want you to bill my insurance company, they check off option 1 and sign off at the bottom of the form. And, again, like we've said before, like, I've literally had, another facility, another ambulance service come in when I've been working at the hospital and have declined transport because, the family didn't have a means of putting $1,000 up front to guarantee transport. I've also had it where this agency has had, being that they have a contract with the hospital, they've held the hospital accountable for that bill because the patient is uninsured and they've got this contract and they have to have like the administrative supervisor sign off on that transport to sit here and say it's agreeable. We had Dr. Jagoda, he sat here one day and said that he sent a lady that was having a stroke out of the ER. He's a physician. He said it's appropriate to send this patient by air, for whatever reason, to Albany Med. That lady came back in with her $50,000 LifeNet bill and said that my insurance is declining it because I didn't have a physician approval to go. So she had to have a special form filled out and had to resubmit it, but she's coming from an ER. She's obviously had some kind of physician interaction. So these insurance companies, I mean, Myra goes to these classes, to be a certified coder and so forth, and then she gets, fear instilled to her because it's taught by all these lawyers and by all these people that know Medicare rulings and Medicaid and so forth, and they know the process and they know what, T's need to be crossed and what I's need to be dotted. So that's why sometimes it appears that, well, all she's worrying about is money. That's not what it is. It's her worrying about making sure that we're doing the right process on our end. She's protecting herself as a coder. She's
Not
protecting
fraud.
the agency,
Right.
and she's preventing fraud of,
Right.
charting.
What a mess.
Where you need to, where I think the patient needs to be informed, if they're capable of being informed, is if there is a possibility that they're gonna be billed in excess of what their insurance would pay. As far as, again, not being transported to the nearest appropriate facility. So a good example, let's talk about a 911 example. You get a car accident at exit 17, and the patient is adamant, I will not go to Glens Falls Hospital, for whatever reason, whatever reason they have, and they insist on being transported to Saratoga Hospital, and we agreed to do that. They need to know that that's, okay, we'll take you there. However, you need to know that your insurance or Medicare or Medicaid may not pay the difference in mileage between what would have been the closest facility, Glens Falls, and what now is the facility that you're being transported to. Because they get billed in the excess and the insurance companies don't pay that.
I thought with this interfacility stuff is new to me because I worked just strictly 911 for years. I did it before a little bit. I wasn't involved in the administrative part at all. I thought once you're accepted by the hospital, Albany Med say accepts you, but we're bypassing Ellis per se or whatever, just give an example. I thought that was all taken care of. That,
Not necessarily.
okay.
Yeah, we've never really
Okay.
seen an issue with this stuff, but there's certainly that capability of getting those types of issues. Like I said,
And I have seen the issue. I
as
have seen
stupid
the
as
issues.
it sounds with like the tenths of a mile, people
Okay.
think that we're just doing it to bust balls.
No.
That's far from the case.
Yeah.
And it's just literally like Glenn's saying, is to prevent fraud or accusations of fraud or any kind of things from surfacing. Because once Medicare comes in, these are the easy things that they're gonna go to and look. They're gonna pick 10 charts and they're gonna probably MapQuest I'm just using that as an
Yeah.
example, Google Maps or whatever, and literally look at the mileage. Like we've literally had patient charts documented that from Home of the Good Shepherd to Glens Falls Hospital was 10.2 miles.
Oh my heavens.
Why?
Error, not paying attention. So, I mean, clearly it's like 2 miles.
That's a big not paying attention.
But, that's a big thing. Like if that chart, if that wasn't picked up by Meyer, or that wasn't picked up by, QA or whoever,
Okay.
We get paid for something we didn't do, bottom line.
Yeah.
Okay.
Exactly. So like she's gonna submit that,
Okay.
assuming that's accurate. And I think even Myra, I think what she does is that she'll audit her own, her own stuff. Like she'll pick so many charts a month and just go back through and, again, MapQuest it from point A to point B and see exactly what it comes out to. And if there's that big discrepancy and it's Derek, she's gonna she's gonna be watching Derek's charts, A, so she doesn't get jammed up,
Right.
and B, she's probably gonna have conversation with QA or with me or with somebody else saying, listen, there's an issue with here, he's not
Okay.
paying attention or whatever's happening.
Yeah, I never knew that side of this nonsense.
And the excess billing stuff, you may not have seen it here, but I've seen it other places. If you haven't seen it here, you will.
Wow.
You will. There'll be an audit. We just went through an audit at my past place.
Jesus.
And that's stuff that they looked at. And, you know, again, because Medicare will say, we will pay the mileage from your beginning, your sending facility to the nearest appropriate facility, and that's what they'll pay.
Wow.
Then the patient's on the hook for
I had
any
no
excess
idea.
mile. Now, again, here, you might be talking a very small,
Here they talk about
minuscule.
contractual allowances, anything, like you can bill $1 million for an ambulance call, it doesn't matter what you bill.
Yeah.
Medicare says we're only gonna pay you $350 for a BLS transport, $450 for an ALS transport, and everything else is gonna be written off. You can't go after the patient for the rest. The contractual write-off, period, end of statement.
right, for Medicare.
For Medicare.
Right.
Medicaid, same thing in regards to like, it's county based. County says that, you know, for Medicaid, we're gonna pay you $75 for an ALS or a BLS call, $150 for an ALS call, and it doesn't, again, matter what you charge. The rest will be signed off because, you know, they're on Medicaid for a reason, or they're on Medicare for a reason.
But private insurance, different story.
Okay.
Private insurance, they have Blue Cross Blue Shield, they can be billed for the excess.
And that's why we, again, have uniform billing practices, and that's why we instill that. Like, you know, if they pick me up, they're gonna bill me the same amount of money that they're gonna bill our neighbor
Right.
if we pick up. Same thing with like, you know, whatever call, RMA, this, that, everything is billed uniformly, and, you know, people will call up all the time and say, hey, can you know, I know Andre, can you do me a favor?
Really?
Yeah, I mean, we hear it all the time, like, you know, and we can't do that, we can't sit here and just write it off, and that's why we tell them, like, we're not gonna bring you to collections by any means over $100 bill. I mean, even if you make a $5 a month payment, at least you're making an attempt at, you know, paying your bill back, but this is all stuff that's done through the billing. Like, I don't discuss billing practices with patients, you know, if they've got a concern on a scene in regards to that, like, you know, we have a billing department that specifically works with that, and we actually have a means of doing a write-off too, meaning if somebody has poverty levels, like if they meet poverty levels, like they have to submit documentation with that, there's an actual form that they fill out, and if they fall within a certain poverty level, like at that point we can write them off and say, well, you're only responsible for 50% of your bill, or you're only responsible for 25% of your bill. But other than that, until that happens, everybody's responsible for 100% unless it's a contractual write-off or they have to pay their copay. And the insurance companies will tell you, we want them paying their copays. If their copay is $1,000, then they're paying their entire ambulance transport, because this is the only way for us to keep our premiums the way they are. And they,
Which are high anyway.
yeah, and they chose that plan. They opted for a high.
No one thinks that'll happen to them, yeah. Okay. Yeah. I
But
know.
anyway, if you're gonna deviate from something out of the normal, as far as facilities go, just make sure you're documenting.
Okay.
That's all. Make sure the patients are aware if they're capable.
Oh, okay.
That'd be my only recommendation.
That's why Beanie got some there, that's why
That would be my
he
recommendation.
wanted to go to.
Okay,
Exit 15.
Obviously, medical history is self-explanatory, current allergies, all those kinds of things. I talk about, I'll get onto that, but current medications, you know, their home medications, those kinds of things. What they've had acutely, I talk about in the HPI. I'll talk about that in a minute. Who it was, obtained from. Obviously, it's just a real quick checkbox, so here we got the healthcare provider. And emergency information form, I don't know anybody who ever uses those, so you can either just leave it blank or hit not applicable. Alright, so let's just say that this person has no allergies and medicines, let's see. Let's see, what else might they like, Wow, I like that. Holy cow, I haven't seen
The
that.
list.
Yeah, I haven't seen that
I
one
haven't
before.
noticed that either.
What?
The list given to ED under
Yeah.
medications.
I don't like that.
Wow,
Yeah,
neither
no,
do I, but it's,
I don't either. But
I've never actually seen
I've
that
never
before.
seen it either.
Of course, everybody's EMS charts is set up differently.
I know.
Every agency
Mhm.
can add and subtract their own stuff. So anyway, we'll just say that that's what this person's going on. Past medical history, obviously they have GERD. Oops. So we'll say they got GERD, hypertension. And this one, of course, is a smoker. Why we're having an MI at 60 or 50 some odd years. All right. Oops.
You know, I never realized you could put smoker, that drop box was available under medical history.
Mhm.
Yeah, I always document that.
Do you?
Mhm.
Okay, I've never, honestly, I've never
And the
done
other thing I'll
that.
do is I'll document smoker and then in parentheses I'll write 1 PPD, 2 PPD for
Oh.
packs per day.
Okay.
That's just me. So
Also in there is.
That's cool, I never even noticed that.
like you can physically write this here like he's
Right.
doing
Mm-hmm,
and then just hit enter
mm-hmm.
and right below that selected area it'll list off what everything you can type everything. You don't need to pick from that screen.
Right, no, I know, I do sometimes, yeah.
Yeah, like I use the pick list to put in gastric reflux, but a lot of times I'll just type in GERD.
Yeah, it's easier.
But alcohol abuse is another big one. So
I think
I don't like that one.
are the ones when you click on them, aren't they coded for Myra or no?
Oh, I don't know.
Oh, I thought I remember seeing that somewhere. Michael.
All right. So your impression diagnosis, of course, again, very self-explanatory. So in this particular case, we're talking about cardiovascular as a primary, and then symptoms. Again, you can check all of these. I'm sure pain is here. There we go. Pain is the primary complaint. Depression. And again, anatomic locations is all pretty self-explanatory. Just gotta look at things like that. I really want to get into meat and potatoes stuff here. So, patient initial acuity. I would say most of the time, they're, for specialty care transport, they're going to be critical red or emergent. The way we defined it in our program in Alaska was if the patient was going to be ultimately admitted to a floor bed and it was going by specialty care transport, let's say it was a high-risk OB or something. They're not going to an ICU setting, it's actually, they're going to, an OB bed. We would call that emergent or yellow. If they were going to be admitted to a critical care unit, then we would call it emergent red, and that's how we coded them. I don't know if that's the way you want to do it here or not, but that's the way we coded it. So in this particular case,
I'll
the
be
guy's
honest with
going.
you, I typically don't document my colors.
Okay,
But I mean, I don't fault people in doing that.
okay, that's the way we defined it. All right, was again whether they go to a critical care bed or a regular bed. So and then again, were they worse, dead, better, whatever one you got there. So this guy was unchanged. So our chief complaint, chest pain. Whoops. Now, what I usually do is if I'm transporting a STEMI or a non-STEMI, I'll put chest pain and put STEMI behind it. All right. Duration of complaint in this particular case, obviously 2 hours. We'll call it. All right. Patient activity, I don't generally fill that out.
No.
I leave the pick list is too huge. I mean, there's things like earthquakes in here and
It's ridiculous.
all kind of, there you go, activity milking an animal. Did you see that?
I saw a fall from a spacecraft or
Yeah.
something.
Oh,
I'm
yeah.
like, all right,
Yeah.
I took a
Or
picture of it with
struck
my cell phone.
struck by debris from a
Yeah,
spacecraft. I've
I
seen
took
that.
a picture of it with my cell phone because no one would
Now, we
believe
had some
me.
interesting ones in Alaska. We had like avalanche injuries, earthquakes, bear
Moose
maulings.
tramples.
Moose maulings, yeah. But no, seriously, I'll show you some charts of some of those that did
That's
bad news. All right, so secondary complaint, obviously same thing. You can always just throw in there anything that's.
Nausea, vomiting.
And again, same duration. Okay, now HPI is where, in my opinion anyway, we get more into the meat and potatoes of things. On a specialty care transport, your HPI is going to be your standard HPI. So to begin with, so for this particular guy, you know, presented to the ER at Glens Falls Hospital with complaining of chest pain, nausea, and vomiting for 2 hours. Your whole PQ, RRRST, or whatever they use now, I use the 4 Rs. And then what's really important is document the sending facility's diagnosis. So, you know, you do your OPQRRST, patient diagnosed with ST elevation MI. Then you document what tests and labs and things like that were done for the patient at the sending facility, as well as any interventions that were given. This is all done in your HPI. So, you know, for this particular guy, upon arrival, received a 12-lead EKG, which showed ST elevation in V1, V2, V3, and V4 for the reciprocal change in 2-3 and AVF. You know, otherwise normal intervals, etc. You document the patient, you know, received oxygen at 2 liters per minute, received vascular access ×2, normal saline at 175 an hour, 325 of aspirin PO, 300 of Plavix PO, 75 of Lovenox sub-Q, etc., etc., etc. So whatever they did for them, chest x-ray was done, no abnormal findings found, whatever they've done for them or tested for is all documented in HPI, again with a sending facility diagnosis. Then the other thing you should put in your HPI is why they are being transferred from facility A to facility B. So patient is being transported from Glens Falls Hospital Emergency Department to Albany Medical Center Hospital for cath lab services not currently available at the sending facility. There should always be a reason why they're being moved and not treated at that particular facility. And again, that's best documented in the HPI. For you, what's going to be important flying, you should also document why they're going by air as opposed to other means.
I was just gonna say, I think that, I like to see that here as well.
Yep.
Why they require ambulance transportation.
Or why do they require specialty care transport services as opposed to ALS services?
Right.
So that's where your billing's gonna come in again, and that's gonna help you get paid and not be questioned. But, you know, for your world, it's gonna be, why did they have to go by air? Was it a time-saving thing? Was it the level of care? Combination of both? Was it, you know, the patient was receiving medications that could not be administered by ground units? Whatever the case may be. Same thing applies here. Patient being transported by specialty care transport team for this procedure and medications being administered not available to an ALS transport team, whatever the case may be. So justify your reason for the specialty care transport. All right. So again, diagnosis, what tests were done, what interventions were done, what needs to be done at the receiving facility that cannot be done at the sending, and then why they have to go by specialty care transport. Or in addition to your normal HPI stuff, is really what should be in there. I'm a little hesitant to do it. I still have access to EMS charts through my other job. I'm half-assed tempted to bring up a couple of charts and have you look at them, just to get an idea of what I've written. So we'll see if I get.
Do you not use page 7 then?
I'm sorry?
Do you not use page 7
Page
then?
8, you mean?
No,
Page 7 should be your labs and fluids, unless you guys have a different page 7 than I've ever.
Page 7's your meds
All
and
your
IVs prior to
medications
arrival.
were given
Yes.
prior to arrival.
Okay, so what I will
can-
do, let me just get rid of that spell checker.
You're saying like if they gave
Like
Plavix
he
or
listed all the
aspirin,
medications that
so
they've
instead of
given.
listing on HPI, you're saying list it up under.
I do, but that's what I'm
I
asking.
put it in my HPI, I won't necessarily put down doses though.
Okay.
You know, I guess I explained it probably in not the best way. Patient received Lovenox, aspirin, Plavix, blah, 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 blah. Got a chest tube and a partridge repair.
Would it be wrong to list it here?
I think you need to do both. I list in my HPI again, and I'll show you one of my charts in a minute. I list in my HPI generally what they got. I don't necessarily put dosages in the HPI. But then when I get down here to page 7, that's when I'll put down Plavix, 300 PO. So I guess I kind of did explain it great. Well, I'll usually just, again, write what they got and sometimes the route, but I don't break it down into dosages and what IV line it went in and all that stuff. I'll do that in page 7. Yeah,
Okay.
I'm sorry. I
Oh,
thought you
that's-
meant,
Oh,
a lot of
okay.
times in the first line of page 8, I'll put a plan of care, and that's where I'll write that out. That's what I thought you were referring to.
Cool.
So your HPI is really important, really important. So let's see here.
I find that a lot of people don't understand what, HPI, I mean, it's realistically your subjective assessment. Like, you go to a scene, if a patient's complaining of shortness of breath, you would document as it relates to that. But it also includes, like, if you pick up the patient at Moreau Family Health, and that doctor's telling you, the patient presented to me with complaints of chest pain, shortness of breath, diaphoresis, that's literally where I'll write it under the HPI is, report received from Dr. Adams, who advised that patient presented to him with complaints of X, Y, and Z, and now patient continues to complain of 10 on 10 chest pain with diaphoresis, nausea, and whatever else, toe pain. But bystander states, doctor states, patient states, family states, I think those are all, nurse at the transferring facility states. I agree with Glenn, I think those are all important parts of the HPI.
And then just a good overview of what they did for them, what they tested for, that kind of thing. Now, like 12 lead EKG, I might put down, noted 12 lead EKG needed STEMI, anterior lateral wall STEMI. And then in my cardiac section, I'll list out exactly the way it ran out. But kind of overview of everything that was done and tested for as well. All right. But a patient's belongings, I've had this come to sting me a number of times. Take a couple of seconds to write down any belongings that you took in or left. I've had it a few times where it saved me calls at 3 o'clock in the morning, wondering what I did with the patient's black purse, those kinds of things. So take that extra
Dentures,
13, yeah.
hearing aids.
I'll do that specifically if I pull somebody's teeth out when I intubate them.
Yes.
And I left them on their bedside table.
Mhm.
Dentures removed for intubation, left on patient's bedside table.
That's the first thing I asked for.
Patient movement, this is all, standard pick list stuff, nothing fancy here. Stretcher purpose, that's a new field for me, I'm not sure what you want in there.
I leave it blank.
Yeah, I leave it blank.
Stretcher purpose,
I
is
think
there
if there's
a
something
patient?
specifically like, patient unconscious or patient, I don't know, typically I leave it blank.
Yeah, I was gonna say, that's a new one on me, I wouldn't even fill that in.
Can't we take that out of there, or is that like a?
Specialty care transports, and
That's
most of them
probably
are
more
gonna
than
need to
he
be
has to
moved
do
by
that.
stretcher. All right, affecting care, we kinda talked about this one once before, not all big deal. Reason for encounter, very, very, again, straightforward, whether it's injury, non-injury. Depending on the program you work with, when I worked for LifeNet did not want us to note drug or alcohol consumption one way or another. That was a number of years ago, but that was their feeling. We didn't note it, we specifically did not note one way or another.
Huh.
My program in Alaska, they wanted us to document it.
They
So,
just told us last week, no.
not to document it. Okay, so that hasn't changed. The reason they gave me, and again, this is old information, Derek may have new information, is they were concerned about billing.
No, they just said. it was-
They can't sign. They're under the influence of alcohol, can they sign or
Right, or
whatever?
drug, right.
They didn't tell us that, they just said they.
No, I don't know,
Not
I'm
supposed to be
just
there.
guessing.
Which, see, for me, it's very, very hard, especially like on traumas and things like that. It's hard for me not to
It's
document.
part of the physical exam.
It's part of my exam.
Yeah.
The one I
It's
do not
purpose.
ever check is the one on patient's breath smells of alcohol.
And that's-
I'll never check that.
I don't think they
Have
specifically
you
said
been-
don't put it there, but that was what they said, don't put it.
Have you
it
been
smell
screwed by
alcohol.
that, or?
Yeah, I mean, a lot of it comes back to, well, how do you know that this wasn't DKA? Are you a drug recognition expert?
As a matter
Are
of
you-
fact, I am.
Well, I know you are, but
Alcohol has-
I'm just saying, this is the stuff, and we had,
The attorneys hate that.
when Jeff Sanger worked here, he was on a car accident on the Northway. And the cop's first question to him, do you smell alcohol? He's like, oh yeah, I smell alcohol. Next day, he was being called down to the state police barracks to give statements about,
Right.
and usually I'll be like, well, I don't know, I don't really smell anything or whatever else, or I'll ask, has he been drinking or something like that, just to feel them out in regards to that. But I'm very cautious, and to me, I never document on there that this patient smells of alcohol. I'll say that there's, drug paraphernalia at the scene, that there's, patient admits to alcohol consumption, patient admits to drug use. Those are things I'll check, but personally, I just steer away from
Well,
smelling of
that's a
alcohol?
bad question anyway, because technically, alcohol is an odorless, tasteless, colorless substance. Pure alcohol.
Right.
So if they say, did you smell alcohol in a patient's breath? You can't smell alcohol.
Yeah.
And a good attorney's gonna nail you on that every time.
Yeah.
What you're smelling is what they call congeners.
Right.
You're smelling the other things that go into the
Right.
fermentation process, etc.
Yeah,
That's a
Hmm.
bad question.
that is.
When I get, and again, everybody does it differently, when I get asked by the police, hey, do you smell booze on that guy? I'll usually just tell them, I'll either say, if I don't, if I don't think so, I'll say, I don't really smell much or whatever. But if I do, I'll usually say, well, I don't know, I'd probably give him a little extra attention. That's where I leave it. And let them figure it out from there, I'd probably give him a little extra attention. And that's where I leave it. But I don't answer it definitively either. Okay. So all these pick lists, again, they're, particularly the cardiac arrest one's kind of important. If you're looking at documenting times, things like that, they're good to fill in.
You're really prompted to those. They're mandatory screens for nemesis. If you pick like reason for encounter as injury, you'll have to
Oh,
fill out
yeah.
the additional injury.
Right.
And this is where you get into that pick list again, where you see, like you can see right there, nemesis 2 injury cause. If you start typing stuff in that, even if you didn't hit that search bar there, to the left in that open box, you can start typing in like MVC, and then like all the MVC options will come up, and it'll say, some of these I don't even know what it stands for. It'll be like NOS.
Spacecraft and accident.
There you go. Yep.
That's what I was talking
By
about.
ground crew or occupant.
You can't
so,
make
Hey,
this stuff
it's a
up.
possibility.
Yep.
Spacecraft.
It's
Jesus.
maybe not here in New York, but
Yeah,
Striking
so,
against furniture.
anyway, right, you get into that nemesis
It's just
stuff, the
insane.
okay watercraft stuff,
Woodwork machine.
X-ray gamma ray
with
exposure.
rolling stock, whatever that is.
We had a guy in jail that would always say that he's been influenced by gamma
Fall
rays.
into well.
And
Did you write it?
The officers would, he wrote it right on his sick call slip, that the officers would be infusing gamma rays to him, he has to be quiet, and he can't really talk that loud to us. Gamma
Oh.
rays, bro, gamma rays.
Your motor vehicle accident stuff, just make sure you're being accurate. If you put down, it can be a big deal, you documenting whether or not somebody was wearing a seatbelt. That can come into play in civil suits years down the line. So make sure you're being accurate, especially when you're talking about seatbelt usage, things like that. All right.
Sometimes those are apparent, because you're obviously cutting the seatbelt off that patient.
Right,
And
that's
but
fine.
if you get there and, the patient's not in the driver's seat and somewhere else in the car, or
Now, when we start talking about these exam fields, for patients that are completely benign, I guess you can use some of the drop boxes, but boy, I hate them, because they generally don't describe exactly what you're looking for. Yeah, okay, alert definitely does that, fine. But it's difficult to use these drop boxes and come up with exactly what you want to say. I tend to freehand most of my stuff in the comments section. So again, all of these things are here. I like this last neurologic baseline scene. Great for our stroke scales, things like that. Definitely important to note with our specialty care transports. If you're doing that kind of a stroke, or you're doing a STEMI, that's really good to know. Whether or not they're chemically paralyzed, of course, is important, because that may obscure an exam down the line, so it's nice to note that. Loss of consciousness, okay, all that stuff. Your GCS, qualifier, real important. Your GCS is usually your best GCS without intervention, right? That's what your true GCS is. So this gives you the ability to note that. When I do down on page 8, for instance, if I'm going to notate a GCS, where is it here?
down.
Down under
Down below
comments.
the comment section, yeah, right there.
Okay, so let's say I have an intubated patient. Let's see, if yours is a little different than what I've used before. Let me see if it allows me to do that. Okay, you have a qualifier. Ours, we didn't have a qualifier, but I could freehand in there, so I would put 3I. Okay, that's a common abbreviation for intubated. So you know that
The
they're
qualifier there could be paralyzed, sedated, intubated,
both.
Patient.
all of them.
Yeah, there you go. So, here, our patient, let's say, is chemically paralyzed.
To me, even if the patient has a
Sedated
GCS
and
of 15, I'm
intubated.
still checking legitimate without interventions.
Yep.
And the same thing with the mentally retarded patient, I might have a GCS of 12, I'm still documented, that's legitimately where he is without us having done anything.
So in that particular case, it lists the qualifiers as well, which is really good to know. Alright. So again, going back up to neuro, I tend to freehand a lot of this stuff in. You know, your sensory and motor, there's a really nice section here to freehand. Works well. You don't have the pupil box, okay.
We should.
I don't see it there, do you?
I thought there was.
Usually it sits above there.
Huh?
It's usually above that box.
It's on the next.
Next slide here, Nate.
Next slide, your respiratory and
No, you
cardiac.
can certainly do it under your page 8, and that could be why it pulls it out too.
Just the person.
Or I'm
I
not,
don't
no,
see
I'm
it
sorry,
there.
not your page 8, your
Hey,
page
page 5.
6 right there. If you click on the body and you do the eyes, you can specifically,
Mhm.
what I typically do with these is I hit the default button at the bottom, and then that brings in all the defaults, and then I tweak it accordingly. So like if somebody's got like a deficit on their right side, they got like dense right-sided hemiparesis, then I'll do the default so that all the normal stuff purges in on the left, and then I'll go back and specifically address the right side where you've got the hemiparesis.
But this is for just the SCT any transport.
Even regular patients I encounter, I'll do all that.
So when you get down to the airway section
This
here, this is a
section?
perfect example. You know, okay, the status is patent. Well,
Okay.
that doesn't tell me a lot. I always write in freehand, I'll leave it patent, and I'll usually put down, performed by patient, in this particular case. Patient is, or excuse me, the airway is open and self-maintained. That way you're really explaining that you're not intervening with this. Because an airway can be patent with a nasopharyngeal airway in place, those kinds of things, or positioning. Positioning, I don't think is part of the pick list. It might be patent with proper positioning. So that gives you the opportunity to explain it, take that opportunity to do that.
Jen, what are you asking now?
I'll talk to you about it after.
Like, if you look at where it's on the left side where it says page 7 PTA,
Yeah.
any page from there up,
Yeah.
5, 4, 3, 2, that's how you find your patient on arrival.
Right.
So it's a little bit different when you're doing an interfacility transport because like under respiratory cardiac, under page 4,
Right.
where it says is the patient on oxygen,
That was.
if you're picking up Joe Blow at home and you put them on oxygen, that's gonna go under your activity level.
Right, on 8.
If they're on home oxygen or they're being picked up at Glens Falls for an interfacility and they're on a non-rebreather at 25 liters,
Mm-hmm. That's
which
where-
we just recently had,
That's where that goes.
you would document it there
Right.
because that's how you found the patient. It was performed by a healthcare provider.
Okay.
On page 8, or I'm sorry, page 7, the assessment, page 5, there we go. There's a defaults button on the left-hand bottom side. Like, if you click
Right.
that right now, it's gonna say, okay. You click okay, you click it again. And then that'll purge in all the normal
Oh, wow.
stuff as it relates to here. Now, if I wanna go in and say, like, he's got right-sided hemiparesis, then I would go over and click on his right arm.
Yeah, that's what I did the other day for my stroke guy.
Yep.
Okay.
And then I would just adjust that accordingly. That's because that's how I found the patient when I got there.
Right. You were in the neuro spot, I think page 3. And what I asked was, this is if we're doing in a facility, right? This is not how we found him.
Well, that's how you found him when you picked him up at the facility.
Right, I'm I'm talking about 911 patients. This is not, we don't use this right here if it's from home, right?
Yeah. You still go through all these pages.
Okay, they've done this differently than at
You're still gonna
another
do.
place.
You're still gonna start at page 1 and just keep going through page 2, 3, 4, 5, and 6. And then this is how because it falls before page 7, that
Yeah.
PTA box.
Yeah,
This is how I found my patient. So let's say
Oh,
like
wow.
here specifically where it says eye opening. Let's say we go pick up a diabetic. We get there, they're unconscious because they got a blood sugar of 12. All right. I might give them a GCS of 5 or 4 or 3. Say it's legitimate without interventions, and then in page 8, I'm going to document my line. IV started, titrate, hung a bag of D10, and then a couple minutes later, 5, 10, whatever minutes later, now the patient's got a GCS of 15, and I can show where his GCS has improved
right.
over
I
the
did
time.
that all in page 8.
Oh. You can,
There was another place I've worked
this
where.
is why I don't document it again on page 8, because I've already
Okay.
addressed it here.
Okay, well, that's better. I like that better. I was told the opposite.
And my
at somewhere
first
else.
line on page 8, on my first entry, I'll always write, upon crew arrival, patient found supine in bed
That's what I do too.
with above complaints. And I don't go back and rewrite
It's
everything.
all repeating.
Because I found people be like, well, they've got left arm pain, and then you look up in your assessment, it's like right arm pain, and they've
Yeah,
like,
mistakes
they've
can be
ma- yeah,
made.
they shows like too much discrepancies.
Oh.
The other thing I'll add to that, what Andre just said, is I'll put down HPI and PMH done as charted, vital signs as
That's a
charted,
good way to
exam
put it.
as charted.
That's a good way to put it.
That's the way I'll write
Okay.
it.
Patient was assessed by paramedic 908
Okay.
and deemed appropriate for BLS transport. Even if I'm transporting BLS,
Mhm.
I still say that I've assessed them as a paramedic and I've deemed them appropriate for BLS transport,
Okay.
just to show that I've done my assessment and I think that there's nothing more that needs to be done.
This is good because I've been wanting to improve my EMS charting because
I don't go back and I try to really stay away from going back and redocumenting stuff.
yeah,
Like,
it
I'll
gets.
see a lot of people document stuff in the HPI that doesn't belong in the HPI,
Yeah.
and then go back and redocument everything that correlates to their whole assessment of above. To me, you're just making more work for yourself.
Yeah, right.
And they go back and redocument everything. To me, your flow in your page 8 should be specifically interventions that you've done, stuff that you've maintained, and how the patient has been impacted by that treatment.
Okay.
Patient has improved, patient is not doing better, you've changed this, you've done this, now we've got an improvement,
Right.
vitals,
Okay. Good.
and then that you've turned the patient over to the hospital. I mean, that's the way I do it.
Yeah.
Yep, me too.
People do EMI at different agencies do them differently, which sucks. Yeah.
But I still do all this, and this is how I found the patient when I got there, because,
Okay.
and that could remain the same.
Mhm.
Like, I could go there and go pick up a chest pain patient, and they're gonna remain alert, they're gonna
Mhm.
remain with a GCS of 15, and I'm gonna show that in my chart, that their condition didn't deteriorate. But on the other hand, if they go unconscious,
Then
they
you'll
could have
show
initial GCS of 15,
on page 8.
and then down on page 8, all of
Right.
a sudden now they got a GCS of 3 because they're in VFib arrest.
I'm doing a whole lot more work for myself than I need to.
Yeah?
Okay.
And again, I do a lot of, again, my HPI would be vitals as,
As
I'll
charted.
put down what I did. Vital signs as charted, past medical history and present, history of present illness as charted.
Dr.
because I've
Daly
already done
hated
it.
us repeating where I used to work.
To me, that just leads to errors.
It does, you're right.
But again, but you did do that. Like Andre said, your page 8 is the things that you did.
Right.
You did do an exam. You did take vital signs. You did take a past medical history and history of present illness. So you can chart that you did that, and you should chart that you did it. But you don't need to repeat the verbiage. You
Right.
can just say as charted.
I just miss pen and paper.
Right.
I really.
That's why even as an ALS provider, like
That's
if,
why I
let's say
wanna
you
get
send,
better with
let's
this.
say you send the patient with Mike Birch, he's an EMT next to you.
Yeah.
You've deemed the patient BLS appropriate. When you go back, you have to sign off on that chart because you're listed in crew 1 through 4. You still have to sign off. To me, you should not be, and I never sign off these charts. Like I sent a patient BLS today. I don't sign off on that chart until they're done,
Right.
and I go back and thoroughly review it myself.
Okay.
Because if I need to add something to that assessment, then I can either do it in the activity log myself
Okay.
as an enter and put it under my name, or I can do an addendum to that chart if I need to.
Okay. All right. Well, this.
Typically, I do it in the chart itself,
Well, this'll
and I'll
help
make
me a lot.
and I'll make note, or I'll make that provider. You need to document that the patient was offered pain management, and despite having pain on 10 on 10 and crying and having obvious deformity, they were offered pain management and ALS interventions and refused such.
Okay.
That type of stuff.
That's really important. Last week I came down three different people, and all three of them, well, that's not how it was. I'm like, well, that's what it says in the chart.
Right. It's not what
And
you
they
do. It's
said-
what you wrote.
And that's what it says in the chart. And they're like, well, I didn't write the chart. You signed it.
Exactly. You're
You
right.
signed it saying you read this chart and it's okay to go. So,
No, I know we're getting off track.
I
but
was
this
just
is
gonna
really
say,
helping
getting back
me.
on track
This is
where we
helping
were.
me a lot, but
With these assessment tabs, these tabs are extremely general. Take the extra time. There are two types of people that document, in my opinion, in the world. There's minimalists and there's maximalists. I tend to maximize my charting, and I can tell you in almost 30 years of doing this, I have never been called to court ever on a medical chart, ever. The only time, for a medical reason or legality, anything like that. The only time there's been times I've been to court when there's been
Because of the case.
PCRs
Yeah.
because of my police background, but never in an EMS related case, ever.
Just turn that coin over. Try being in a court with somebody that has an awful chart,
Minimal documentation.
okay, minimalist, like you're saying, on a chart, they will tear you apart.
Yeah.
And people laugh at me, like, when I sit
No,
here and
I've
look at,
been there, but luckily I
when I
had a
look
good
at
chart.
charts, like, with people that use proper nouns, as stupid as it sounds, they'll put, you know, Jennifer Costa, all lowercase letters. You know, this is the stuff that I've seen, I've had to testify in grand jury from nursing when I worked in the jail. These lawyers look for minor things like this that have nothing to do with patient, just to try to get under your skin and sit here and say, when did you learn proper nouns? Well, when I was in elementary school. So why are you documenting, Jen Costa as, what are you, an idiot? Like, how can you sit here and give medicine if you don't even know if you don't even know what a proper noun is? And then you'll be like, what are you talking about? Again, we're going off track, but.
I know. No,
It
that's
destroys the
And
legality of the
attorneys with
document.
case selection as well, and again, this is going back to my law enforcement days, with I did over 1,000 DWI arrests in 20 years. And I would rarely, if ever, unless it was a big profile case, get called in for anything besides a grand jury to indict, because there's two things the attorneys always told me they look for. Number one is the reputation of the officer or whoever wrote it. So if you have a reputation, good or bad, as a paramedic, that can help you as to whether or not you may be called, be called on the table even for medical malpractice or whatever the case may be, for making errors, because if you have a reputation of being a poor paramedic, they know they can get you, they know, there's money in it, as opposed to they know you're solid. The other thing they look at is paperwork, like Andre said. If they look at a properly written, well-documented chart, they're less likely to go after you, because
They project the stuff on screen in court.
yeah, they
Oh, I
figure
know.
they're not gonna get anything out of it, because you're gonna.
Each juror has their own
You're
screen,
tight.
you have a screen, the
Yeah.
judge has a screen, the cross-examiners have screens, and they'll pull it up and they'll say, it could be clearly written, they'll be like, Andre, I want you to read your nurse's notes
Yeah.
from June 12th,
No, I've been in
2006.
them for like murder trials and stuff, but
Crazy.
not against my chart, but with my chart, and you gotta have it all.
But yeah, you end up in a trial
Right.
though someday.
Exactly.
What you write and how you write it can make a big deal.
Well,
So
I-
don't just use the drop downs is what I'm
Yeah, well,
telling
I
you.
appreciate that.
So don't be afraid to freehand. That's what these boxes are for, and I use them.
Sorry to get you off track.
That's okay. No, that's fine. And again, that's why I comment. The airway is open and self-maintained. So instead of just hitting P. A lot of people, the default on this, now I'm gonna erase everything here, but the default on this, I didn't do it. Cancel changes, defaults, it didn't do it. But if you just, without what I put in here, the only thing that says under airway is P. That
Yeah.
really doesn't tell me a lot 5 years down the road.
Yeah.
Okay. Respiratory and cardiac, same thing. I usually write in here also that there's no dyspnea or there is dyspnea. I write their room air sat or their saturation on whatever oxygen they're on, what their work of breathing looks like, all those kinds of things. Again, when you initially assess them, how you find them, not necessarily how they progress.
Incidentally, we've seen patients in cardiac arrest, obvious death, have normal effort and clear bilateral breath sounds.
Yeah, because of that default button.
With good purposeful movement.
You've got to pay attention. And this is the stuff that like when Derek put in for the supervisor stuff. I'm like, and he's dealt with this at GABAC too. I'm like, this is the stuff that I want looked at, because people do not pay attention to what they document, and this is why I personally will not sign off on a chart until it's done and signed off by the person doing the chart.
Okay, so under the respiratory section here, you have this ventilator tab. Again, keep in mind, this is for how you found the patient, not what you did to them. So when you bring this up, your mode of ventilation, according to what was that respiratory therapist from? Saratoga. So any patient you take out of Saratoga Hospital, under all circumstances, always will be on assist control. All right, so that means they're gonna be what form of ventilation will they be if they're on assist control?
Can't really read it.
Could be pressure or volume.
She's saying assistant.
Volume,
Assist control is gonna be volume control, right?
yeah.
You could do pressure too.
Yeah, I guess you could, yeah. I mean, you're normally gonna select up here. Yeah, okay, I'll buy that. Yep, you're right. So in their case though, they're always gonna be volume control. So they run a rate of 12 with a tidal
500.
volume of 500. Their eye time, or rather their inspiratory pressure was 20. PEEP of 5, FiO2. Now, what's your FiO2?
80%.
80%, is that what you're right?
No, I don't know, whatever they have it set for.
It's usually a decimal, so 0.8 actually is the proper way to, 80% would be 0.8 or 0.8, however you want to do it, is technically the correct way to do it. I time in seconds, 1.0. Pressure support, they're not on any, so I'm going to leave it blank. Flow rate, now the flow rate sensitivity is set, but your mean airway pressure, your flow rate, things like that, these are things that you're going to get off the machine that they're actually going to read it to you. All right, your peak inspiratory pressure, auto PEEP, your plateau pressures, all that stuff, your IDE ratio, there's all going to be things that are the machine is going to display for you, so you don't need to do that. So that again is how you found the patient, not what you necessarily did to them. Pulses, again, you have this wonderful default button. Radials are strong, but if you did something else, make sure you put them in there. Particularly if you're taking somebody with a balloon pump, making sure that you're doing femoral pulses is very, very important. So let's just say they're bilaterally weak. You know, if they got something in their groin, or if they went for a diagnostic cath. Correct me if I'm wrong, Saratoga still does diagnostic caths?
Yeah.
So I
They're
don't,
gonna be up and running soon for intervention.
so you may get a patient where they've gone in, they've put a sheath in, they've done a diagnostic cath, and they found a big old clot that needs to be ablated. Okay, yeah, that needs to be extracted. All right, that needs to be stented. They'll many times, unless again things have changed around here, they'll leave the sheath in.
I didn't even know that, really.
Yeah, they'll leave the sheath in. Well, why send them to the cath lab? Why send them to an interventional lab? Why pull the sheath out, send them to an interventional lab, and have them reinsert a sheath? It doesn't make any sense. So they'll leave the sheath right in. So remember to check your
If
your
they're sending
pulses.
the patient on an inner aortic balloon pump, they will be sending a perfusionist with that pump. So it's not like we're gonna be responsible for that. Huh? Well, I mean, that came from Remo. You know, at the MAC meeting, they wanted that, and they wanted to specifically address that we do not transport pediatric patients. So initially, I had an age limit of 8 on there for special care transport, and Dr. Jagoda wanted us to have it at 12.
12, right?
So 12 and above are okay, under 12, no. Inner aortic balloon pumps will be, you know, managed and transported with a perfusionist. So,
Big common mistake I see is under temperature, people will leave this as centigrade. See that a lot. The default is centigrade. So make sure when you enter a temperature, you change it to Fahrenheit unless you're doing it in centigrade. But I see a lot of times people will
It
not
won't let
change
you
it.
lock it here.
Huh?
It won't let you lock your charger.
Okay. That's so yours is set up.
what do you mean?
If you leave it in centigrade, put 99.
Yeah, if it's, oh, that's what you're
It's
saying.
outside of
I
it.
know Glens Falls Hospital, they take their temperatures in centigrade,
And that's
Yeah,
fine.
but
Just
that's
all I'm
the same
saying
if
is
you-
make sure that
correlate.
they
If you have like a,
If you put in
99
degrees
Celsius would
it won't
suck.
let you lock your charger.
Right, right.
99 Celsius.
If it's 32, it would be fine.
Yeah.
Yep.
So again, use your comments section here under cardiovascular. I'll usually write what's going on with them. ECG equals normal sinus rhythm with normal intervals at 60 beats per minute, comma, no ectopy, 2 millimeters, 2 millimeters, ST. So I'll actually document that in there. That's the wrong abbreviation, isn't it? Is it AVF? No, that's not right either. Andre? I'd have to look.
Lowercase a, VF, yeah, capital.
Okay. So that's the way I'll actually write out my 12 lead, or excuse me, my EKG finding and my 12 lead findings, you know, right in the comment section there. Oops. And I don't know how you feel about this, guys, but I write normal intervals. If their QRS is normal, their PR interval's normal, all that, I just write normal intervals. I don't go through and list out each individual one. If they have an abnormal interval, I'll chart what that abnormal interval is, but otherwise I just write normal intervals. Heart tones, does anybody check them? I'll be honest with you, I can't pick it out, so I don't chart it because I can't.
If I hear it specifically, then I'll document it, but, other than that,
Unless they got an LVAD, I
If
can't.
it's blatant, you know, just for, cause it's interesting if you could hear it, you know what I mean? But
Unless they got an LVAD, I can never pick it out.
well, I mean, what's in the drop down though? Like, you know, like I was, you know, like specifically if I'm listening for an S3 on somebody in congestive heart failure. I mean, it's, you know, it's not realistically what you're seeing here. You hear decreased on muffled sounds. You hear a murmur, normal. I mean, what
it's,
tones diminished? I mean, the options that are there are shitty.
they are.
You know, to me, I want to see normal S1, normal S2, S3, S4 on auscultation. Those are the things I'd like to see, but I don't really see anything there that I would check other than normal if I'm specifically listening.
Heart
for it.
tone's not present, but you can't put anything in there. That's interesting.
Yeah, it's
Well,
off of
if you
that
do-
that
yeah.
drop down.
See on the left-hand side where it says not present and then red?
Oh, okay.
If you
Oh, and it'll just
click
bring it up
those,
there.
it'll put the
Okay,
not
gotcha,
present there
gotcha,
and the
gotcha.
present. That's where I get thrown off sometimes when I look at charts. I'm like, why are they sitting here documenting that the patient's alert oriented times 3, but they're in a rest? And then I go back and look again and it's like, you know, mentation not present, and then it'll say they're not alert, they're not oriented, they're not, you know, to me I don't go to that extent.
Yeah.
That's me. More documentation with that kind of stuff.
So secondary survey, we pretty much covered this. You know, again, you pick on the little box and it'll give you different things that you can check and those kinds of things. Down here though, there's a real important box, drains and tubes. This is where your Foleys are, your NGs are, chest tubes, all those things. This is where you document that. And in the others comment, I always mark down like how much is out, my ins and outs. So, you know, Foley produced, you know, 1,000 milliliters of, reported to have produced 1,000 milliliters of clear yellow urine since admission, or whatever the case may be. But drains and tubes, this is where all the stuff that was there when you got there, you document. So this guy has an 18 NG tube because I put it in. Whoops, low continuous suction, no OG tube. Okay, so chest tube, there was a 36.
Now again, if you're putting in the orogastric tube in the arrest or vented patient, that should be documented under your page 8.
Yeah, but see, I brought this guy in,
Right, no, I
and then
know.
they decided to specially
I'm just-
care transport him out, so this is the
Drain.
second chart, really.
Under drain.
Now you're confused.
I'm kidding. 16 fully, so we'll go with clear. So then I'll just put down,
And then in 8, you'll say how much he's outputted in his Foley while he's with you.
right.
Okay.
That's gonna be important for patients that are, you know, when they're specifically monitoring
CHF.
their urinary output
Kidney issues.
or kidney function.
Yeah.
You know, maybe they're in like complete shutdown and they're not producing any urine and
Right.
you're doing a full transport, even like an hour. I mean, realistically, the minimum urinary output on a patient should be 30 mLs per hour. During that transport, you should have some kind of urine. If you look at that and there's nothing in the tubing and nothing in the bag,
It's a problem.
there's two things.
It's kinked
Either it's not in,
or he's in trouble.
kinked, or he's really not producing urine and, you know, he's in shutdown mode.
So don't be afraid to use the comments again. So you see here, even though we noted that he's got chest tubes and a Foley and an NG, I explained that. So Foley drained 300 milliliters of clear yellow urine since admission. No drainage noted from the NG tube or chest tubes. So document that stuff in there. But that's a really important box. Your burn box, this is where you can actually put in your estimated percentages. What I will tell, and there's a couple different ways you can do it. What I will tell you is that most of the time with burns, you underestimate. Most people underestimate, and especially over time because they blossom out. So just keep that in mind when you document. But here's where you put in your burns, and you can switch over to rule of nines if you want to do that. So there's several different ways to put it in. Back to total body surface area. So you can do it by TBSA or switch over to rule of nines, however you want to do it. Several ways. All right, so those are the two big ones down there. So that pretty much does page 8.
For specialty care transports, we should not be using the default on this.
No, of
I will be
course not.
flagging it every
Oh,
time.
yeah.
If you use the defaults, do a
Of course.
physical assessment and document it.
Yeah,
So
The
there's
defaults
your
are really
defaults.
just used for BLS calls.
yeah.
I think I might use them, but I will go back and fine tune them and tweak them.
Yeah,
You know, as long as they're appropriate. It goes back to that patient that has clear bilateral breath sounds that's in cardiac arrest. I mean, that's clearly showing you or the next person that you're not paying attention to that patient.
Yeah, or the unconscious patient that you
Has a pain airway.
yeah, or moves all extremities well, those kinds of things. So, okay, so again, page 7 is prior to arrival, so their IV access or their vascular access prior to your arrival. Very simple, it's nothing different than we normally do, you just add it in. Then your medications, again, what they have gotten prior to arrival. Now, let's say West Glens Falls brought in a cardiac arrest victim. This is my way of doing things. West Glens Falls brought in a cardiac arrest victim. They got ROSC. Glens Falls has them for an hour in the ER before they're going to transfer them down to Albany for a cath. In my PTA, I put West Glens Falls meds in there as well. Everything they got prior to that. Now, where this can get really ugly and complicated is somebody who's been in the hospital for days or weeks.
yeah, like how
Then-
far back do you go?
I go back 24 hours. I don't know what you do, but I go back 24 hours.
The problem with that, with documenting like West Glens Falls stuff, A, do we have the chart to reference, and B, is the Glens Falls Hospital documentation accurate as it pertains to that? Sometimes they'll come back and, how many times are we in there saying, well, we gave 6 Eppies, we gave, 2 atropines, we gave sodium bicarb, and nobody's documenting anything. And they're trying to, I'm not just saying Glens Falls, I'm just saying wherever. I mean, I know at Saratoga Hospital, when there's a code that comes in or a critical patient that comes in, there's specifically somebody that's dedicated to documentation.
Right.
Like you have a dedicated document, almost like when you watch the American Heart Association videos.
And
it
like
shows
Albany
the-
Med in the trauma room.
Exactly. There's a dictator there.
Right.
But if they say, if I go into Glens Falls, I'm just using them as an example, and they say, yeah, came in by ambulance and got 3 Eppies pre-hospital, shocked 5 times, and got 300 of amiodarone, I'll document that stuff in my prior to arrival, because that's important for the receiving facility to know what they got prior to that. And again, for the long-term ones, there's probably no official policy on it here. I go back 24 hours is generally what I do. Medication pertinent negatives. This is a field, Andre, that I have not seen.
I don't document it in there.
Okay, same thing with procedure pertinent negatives?
Nope.
Okay, I've never seen them. Just a recommendation I would make, have them pulled out. If we don't use them, pull them out. That way nobody can ever question why you didn't fill them in. Now, page 8, again, this is a style thing. A lot of it depends on how Andre wants things documented. For me, I usually, in my first sections, when I make contact with the patient, I usually note again what I did. I did an exam as charted, did vital signs as charted, blah, 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 blah. And then I'll usually also write a plan of care, just a brief, this is what I plan on doing with this patient. And it might be, treat acute coronary syndrome per Remo and American Heart Association protocol, or the case may be, or, I'll show you some charts that I've written.
I'd like to see that.
Yep. With page 8 too, whenever you give a medication or do a procedure and you note that, you use a drop down for that, you should always give the reason why you're doing something and what the result was. So I see so many times people will document Zofran 4 milligrams IV. Okay, did you give it prophylactically because they were secured supine to a backboard and you were giving them morphine as well? Great, that's fine. Just document that that's why you were doing it. And the result was they did not develop nausea. Or did you give it because they were actively nauseated or vomiting? That's just a really poor man's example, but always give what you're giving, the dose, the route, all those, 5 right things or 4 rights, whatever it is. And then also why you were doing it and what the outcome was. Now,
Dr. Jagoda likes seeing, especially with controlled substances, he likes seeing a set of vitals 5 minutes after its administration and how the patient reacted to it. So if you're given, 5 milligrams of morphine, right? Am I right, Derek? 5 milligrams of morphine for right hip pain, 5 minutes later, he wants to see that the patient's vital signs were reassessed. And he also wants to make sure that we're assessing vital signs before we're administering controlled substances.
Right.
Because clearly if a patient's got a blood pressure of, 70 on 30 and we're giving them morphine, we had a situation where the first set of vitals wasn't obtained on a patient at all except 20 minutes after a controlled substance was administered. Twice. And that blood pressure was hypotension. It was a hypotensive blood pressure. So, and the question from Dr. Jagoda is, what, was he hypotensive before? Or was he hypotensive because we gave Versed to this patient? Twice. So just keep that in mind. I think Len brings up a good point that, we're not only talking about controlled substances. Any medication that you give, you should be documenting some sort of, if you're giving amiodarone because they've got, bigeminy and they're, symptomatically in bigeminy on the monitor, then, did that work or did it not work?
Yeah, Dr. Jagoda's good on 5 minutes after. I prefer 5 before and 5 after. I'll usually let you get away with 10 before, but anything 10 minutes before or before that, you need to have within 10 minutes of doing narcotics.
What do you think of oxygen? You document that as medication administration or not?
Sometimes,
Should.
I should,
I do it under airway.
yeah.
See,
Yeah,
I
it
don't. I
depends
do
on-
under-
The only reason I don't do it under airway, or don't do it under medication, it's fine if you're doing an ALS chart. If you're doing a BLS chart and you document under medication, it flags you and requires you a REMAC run number to close it.
Really?
Mhm.
Okay.
Now, from a billing aspect, this is just what I've been told from the billers, and the company I worked for was recovering about $75 million a year. From a billing aspect, when you get into like ALS1 and ALS2, oxygen is medication. So if you give oxygen and aspirin to somebody, 2 medications, ALS2 bill.
No, ALS2 in New York State, I don't know. ALS2, it has to be 3 IV only medications,
Okay, yeah.
okay? It can't be 3 doses of sublingual nitro.
It had to be different
It can't,
medications,
no,
but
it
it
doesn't
didn't
matter.
have to be.
It can't be nebulized medication.
Those are
It
BLS.
can't be oxygen. It can't be a Zofran sub ODT and an IV morphine. It has to be 3 IV push medications. It can be all the same.
Wow.
It can be morphine 5, morphine 5, morphine 5. It's 3 IV push medications.
See, the way our billing department explained it to us, it had to be, I thought it was 2, but 3 medications, but it had to be different medications. So
No.
that's why they had it built that way. But anyway, so that's interesting. Now that I didn't know that with you guys, you could lock it without an ALS run number if you were to document oxygen.
Now, if you're doing an ALS chart anyways, if you're putting an IV
Right.
in and you're getting a REMAC run number, there's no
So
issue.
that is really weird.
Mm.
That is.
And I think it's a Nensis thing, to be honest with you.
Yes, we could close them down. Well, of course, we didn't have another run, so it doesn't. Okay, interesting, I didn't know that. Good to know. Good to know, so we'll give this guy some nasal prong. Concentration doesn't matter, complications, none. Response unchanged, so in this particular case, because I had already documented that this guy was asymptomatic, had no dyspnea rather. So oxygen, I'm making this up, oxygen administered according to STEMI protocol. So That's why we gave it. So, and we've already talked about that there were no complications and the response was unchanged. So as far as I'm concerned, that's enough. If there were any complications, or there, I mean, I guess there was anything more than you just got better or worse, I would explain that more down there. But again, the reason why you gave it. Wow, that is really something that you can't close it out with an ALS run number. Huh.
Well, what I prompt people to do, Glenn, to be honest with you, is if they list oxygen under medication, merely putting a period in the REMAC run number is enough to close it.
Oh, okay.
So, as stupid as it sounds,
Yeah.
if you put it under medication,
Just put a period.
just put a period in the REMAC run number and it'll still close. Because you don't need a REMAC run number for that. You don't need a REMAC run number if you're just doing an EKG. You really only should be getting a REMAC run number if you're doing interventional stuff.
Okay, say the period thing again.
Like he's,
Okay,
see
so
how
I'll
he's,
go right to it, Andre. I'll
yeah,
go
if
up
he
to it.
entered oxygen under medication and it was like a BLS call,
Yeah.
under the REMAC run number up there on the right,
Yep.
you can just put a period there
Okay.
and that will be enough to close the chart. If
Okay.
you find it necessary to put it under a medication.
Okay,
If you're just putting it under airway, then it won't prompt you to give a REMAC run number.
okay.
So some of the other things with page 8, you know, be very, very, in my opinion, I always document my moves too. You know, if I move somebody from point A to point B, I document that that was done and how it was done. Particularly if they have an endotracheal tube in place,
Oh,
you
yeah.
should always document that every single move you do, you need to document afterwards that the endotracheal tube was patent. So I usually write that out the first time. So what I'll do is, let's say I moved them from the bed to my stretcher was the first move. I'll put down, you know, endotracheal tube, confirmed following move by the following methods. Auscultation of bilateral breath sounds, negative epigastric sounds, continued high end tidal, or excuse me, SpO2 and end tidal remained with good qualitative and quantitative measurements. And then what I do is I copy that, and every single time I move the patient, I just paste it into that line with that move. And it's just right there, it spells it out. So I don't just write ET tube confirmed after move, I actually write down how I did that, but then it's easy from there out in, forward, because you just copy and paste each time.
Good
Copy
idea.
and paste it right in.
Okay.
So let's see, we covered, medications covered that.
Yeah, what about Glenn, like if you've got a patient on norepi,
Mhm.
we would do a separate line entry because we're maintaining that for transport, right?
I would, yeah,
Is that what you guys do?
yeah, I would.
Yeah, I haven't done that, you know, just tried to, so.
Oh, you have not? You guys will do EMS charts that you haven't? Oh, okay.
Yeah.
My thought is that if you've got something hanging, propofol, norepi, dopamine, any of those critical drips, if that's something that we're maintaining for transport, we should be documenting that under the tab titrate. And that's the same thing that I do with IVs, like when I'm starting an IV pre-hospitally, at the house. If a patient is picked up and I'm giving them a normal saline bolus, let's say I'm giving them a liter of fluid because they're tachycardic, hypotensive, and they meet protocol to do that, I'll do an entry for initiate IV,
And then a medication.
and then I'll do another line entry for titrate,
Okay.
and then I'll do normal saline, you know, and then I'll just document normal saline at wide open rate times 1,000 mLs, followed by a continuous infusion at 500 mLs per hour.
See, now what I do is, because I consider normal saline a medication, I do a
You can do it under
medication
that
line,
stream, Yep.
administered normal saline, and I'll put in 1 liter, and then after that, I'll put titrate, and then I'll put, you know, 1 liter infused now at 175 an hour, or 125 an hour, or
And
whatever.
a lot of that's gonna be by your physician's orders when you're doing
Yeah.
inter-facility stuff. And to me, it's just maintaining that, and if you make a change to your norepi, let's say you start at 2, and then you go up to 4. You should have a different line item for that, you know, a different line entry,
Yeah.
to show, and then again, going back, you're making a medication adjustment, you should be, you know, clearly documenting and monitoring their vital signs, because norepi is gonna affect their vitals. Propofol is gonna affect their, you know, sedative
And
status.
why. And again, why you did it, and what the result is. Same thing, vent changes. When, you know, when you pick up this patient that's always on assist control, and you switch them to SIMV, and you take them off volume, and you put them on pressure support, or pressure control ventilation, whatever the case may be, you're gonna wanna document your reason that you made that adjustment. And when you bring up the vent tab, there's actually a separate line. So what I'll do is when I move, Andre, again, I don't know how you do this. So if I just pick somebody up at Glens Falls right now and they're on a vent, I hit the ventilator tab and it's gonna tell me I got it.
Yeah, you wrote the ventilator options under respiratory cardiac and there, or maybe it was neuro airway, whatever, page 3 or page 4, that would be the initial setup as you got there. I would do another, personally, I would do another line entry saying vent settings as above. And then if there's been no change and no need for a change in vent settings, then I wouldn't document all those vent settings again.
Yeah.
If
Yeah,
I
I think
did
that's
adjust
fine.
something, then I would do another ventilator entry. But I'm also documenting in my narrative as I go along, you know, no change in patient's condition, ventilator settings maintained as per transferring facility orders, patient remains, you know, well sedated, vitals as documented, you know.
Yeah.
So here when you hit your action tab, it'll give you, you can either, you're initiating ventilation with the ventilator or you're changing the settings. So initiate, again, if you're gonna be doing SIMV, we'll still do volume control, that's fine. This is all, so this was actually, yeah, you know what, it plugged it in. It plugged in everything from our initial thing.
Right, yeah.
So it's all there. And then I'll generally put in something in here in the comments like, you know, moved from bedside ventilator to transport ventilator, patient tolerated change well, you know, saturations remained, whatever. And, you know, I document how they tolerated that change. Then when you're gonna, like Andre said, when you're gonna do event change, then you just go to change ventilator settings, and then whatever you change it to, because your initials will stay recorded. Type, and still at volume. So let's say we increased his rate to 16 as well. Kept his tidal volume the same, that was at 500 before, we'll keep it the same. And 5P, oops, excuse me. 5P. And anyway, any change you made, and then you just, again, rationale why you did it, why you made these vent changes. There's a thing here that says vent change rationale, and you can pick stuff.
There's nothing there.
How come it didn't come up? Well, the charts I used to use had a bunch of pick lists here, but again, like Andre said, I didn't like the choices, so I freehanded everything out. The reason why I made my vent changes. You want to document that. And what their response was to it and whether there were any complications.
You just don't want to repeat stuff. Like, you know, like I said, once you start talking about body parts, meaning, you know, left arm versus right arm, and you start deviating from that and repeating stuff, you find a lot of discrepancies in the chart. And those are things that I'll flag people on. Like, I'll come back and say, like, you know, you've documented that the patient's got left hemiparesis in your initial assessment, and then in your documentation here, you're writing that he's not moving his right side, and he's got, you know, adequate neurological function in his right side. So, I mean, you're just, like,
Yeah.
having discrepancies on both sides.
Yeah, it is easy to make mistakes that way.
Oops. Oops.
907 area code?
Yeah. Trying to find one that would be real nasty in the hospital. I'm just trying to find a real nasty in a hospital.
Okay.
Some of these I'm going back a ways, so I'm having trouble remembering. I'm just gonna pick one because I'm having trouble remembering which one's which. Alright, so this is, so this is a STEMI, here you go. So this is, I don't know who wrote this chart, myself or my partner. I can actually tell you by looking. My partner wrote this chart, not me. So let's see how he did. So starts right out with the normal, you know, PQ, RR, RRST, right? Pain scale, lasting a couple hours, all that good stuff. Associated with sweating, mild nausea, but no shortness of breath. Went to the ER by himself, by private vehicle, complaining of above. They did a 12 lead, which revealed ST elevation of 2-3 in AVF, consistent with inferior wall STEMI. IVs were started, the patient received aspirin and sublingual nitroglycerin. They drew labs and made transfers arrangements through us to provide safe, rapid, critical care level transportation of the patient to Providence. And that is a standard line I use. I always write, you know, Moreau EMS was called to provide specialty care, safe, rapid, specialty care transport of this patient to Albany Medical Center Hospital for cath lab availability, interventional cath lab availability, not currently available at the sending facility. So again, here, safe, rapid, critical care level transportation patient to Providence, Alaska Medical Center in Anchorage for cardiac catheterization lab availability not available at the sending facility. Ground transport of 50 minutes versus 18 minutes by air. Not applicable to most people in the room, but will be to you, Derek. And then, again, I just write down ER staff also administered Plavix, PO, fentanyl IV, heparin bolus. That's a lot of times more than I'll put in there. I'll usually just put the meds that they received. So that, my partner did it a little bit differently. But, you know, again, under the comments, moves all four extremities with equal strength and with purpose. So not just the standard defaults. The airway is open and self-maintained, all the stuff we talked about. Labs, so the guy's troponin was actually negative. That's interesting.
That's weird,
Yeah, just early, that's all. They got the blood quick.
yeah.
He hadn't popped his troponin yet. So here's your I's and O's down here. These are his IV infusions going. So he was getting Activase as we got there. And these were the medications, again, with the dosages that they had given him prior to arrival. So arrive at bedside. See, now what Andre talked about, my partner again wrote this chart, and I tend to be an English and grammar kind of Nazi, but you know, again, not capitalizing the beginning of the sentence, those kinds of things. That stuff all matters, you know. And then I usually throw a plan of care in here. Did he put one in here?
Yeah.
Yeah, POC, plan of care. Keep oxygen saturated above 92%. Medicate IV for pain. Heparin infusion followed by bolus, following bolus rather. Holding the metoprolol because of his low heart rate, makes sense. Titrated nitro drip to keep him pain free. Give him some oxygen for protocol. And that's it. And then everything we did. And yeah. Now, one thing that, yeah, no, that's fine, because that's a titrate. Yep, that's all right. So that was just a STEMI, pretty standard STEMI right there. A pre-hospital STEMI.
Probably write it in your search bar.
Huh?
You could probably add it in your search bar and narrow down the search.
Yeah. I'm looking for Copper River. This is one right here. So this was a STEMI this was a chest pain we flew out for at 7:30 in the morning, and you can see it took us from 7:41 to 8:46 to get there, so an hour and 5 minutes to get to the scene.
Wow.
But this was a guy that was having chest pain in a remote area, BLS ambulance picked him up. So, but again, this is a scene, but the reason why I wanted to bring this one up is because of the page 8, the way everything is documented. So, cardiac, the reason why cardiac's there is we check because we take continuous cardiac monitoring on 12 lead. Medicine, aspirin, initiate an IV, medicine, nitroglycerin, initiate another IV, give another nitro, gave Zofran, and again, you can see 4 severe nausea and vomiting, status improved with medication administration. 12 lead, put defibrillation pads on, administered T in case,
Where is it?
Comstock Road.
got a med for administering T in case, and again, explaining why. All that's in there. But,
Thank you.
you know, as you can see, there's a lot of documentation here.
Yeah.
It's not scant, and this is the kind of stuff that'll protect you down the line. Anyway, Andre, that was kind of, again, kind of an ad lib thing, but anything else you'd like to?
I appreciate you showing the
What I wanted, Glenn.
kinda-
All right, let's finish up a couple things. Glenn, you have anything else with this?
No, not really.
Exactly what I wanted, though.
Thank you.
It's good to, I mean, it was more of a discussion than anything, but I think that was good.
Yeah.
Dre, about how long do you think?
Couple more minutes.
Okay, that's fine. I have 32 minutes left.
Yeah.
so.
Much easier. Yeah, once you get used to it.
All right, so the last thing I want to go over is just some documentation stuff. This binder will eventually get out. I'm just trying to fine tune this stuff as it relates to the protocols, procedures, charting, and so forth. So I just want to quickly talk about these things and then we'll get out of here for today. In regards to the Chuck Margaritas lecture, I'm still trying to figure out a date in regards to him to come back so we can do that class that we're supposed to have on Saturday. And then Glenn is going to do another vent class once we get our vent that he's acquired for us from Alaska. We're going to bring that vent in. We're going to do training on that, lecturing on that, and then I'm going to send it over to Omnicor, the company that was doing all our biomedical maintenance stuff today, and they're going to have to certify it and get it back into service for us. And then once that's done, we'll have it available for our transports and hopefully be able to just do our own vent transports without needing an RT with us. And I think that'll be a big move for them, the hospital too.
Same vent that, for the group, the same vent that they had here the other day.
Yeah.
Nice.
Great. So the first part of this just talks about EMS, critical drips and infusions. This was basically the PowerPoint that Adam Young had done while he was here. This talks about the different medications, a graph that he had put together in regards to what ReaPro is, what all these other medications are, the dose, the boluses, and what to monitor for. This is emergency guidelines as it relates to specific drugs and drips. Drips, more drips, okay? Those are all drips here as we relate to it, and then like, these are graphs as it relates to like norepinephrine. Let's say you have a concentration of 16 milligrams and 250 mLs, that's what they'd be started on there. If the patient weighs 77 pounds, you know, if they're starting it at 0.4, the drip would be 13.13. Those types of things so that we can just refer to graphs as opposed to trying to mathematically do things. These are all things that was set up and available for, and a lot of those things with the pump that the Glens Falls Hospital, Baxter was talking about, it's already programmed within the computer, right? That you could sit here and make those adjustments accordingly based on the patient's weights that's punched into those computers. But bottom line is that when you can reference these things and make sure that things match up, you know, it'd make you feel more comfortable knowing that you have the right rate setting on that pump. I put together the specialty care transfer orders. It's a 2-page form. All right, sounds like a lot. It talks about obviously who's transferring the patient, who's receiving the patient, what the patient's been diagnosed with, how often they want you to fill out and do vital signs, is suctioning required, administration oxygen, cardiac monitoring, IV, IO sites, tapering doses, sedation and analgesia. I specifically listed the medications we carry, such as Versed, morphine, fentanyl, and ketamine. And this is, like we've talked about with Dr. Jagoda, it's not like we're going to go in there and just have like standing orders to sit here and do as we wish as we go, because these physicians really should be having an input in regards to what they want for those patients. If they want that patient being sedated with Versed every 5 minutes on the way down, then that's something that they're going to document here on this flow sheet, on this order sheet, okay? On the back, it talks about tracheostomy tubes and endotracheal tubes, talks about ventilator settings and what normal parameters are, additional transfer orders, they sign, they print their name, date, and time it. Here's a sheet on scope of practice as it relates to SCT. This is stuff that you guys can review. I'll put a copy of this binder into the boardroom once everything's been finalized and signed off by Dr. Jagoda, so that you guys can have an idea on what this book is going to contain. All the books will be the same. Each ambulance will have one. We'll also have one probably here in the radio room for perusing, and we'll have one in the office so that we'll have consistent books throughout. So that would be 4, 5, 6 books, right? Binders. General expectations, transport formulary. We basically, when we talk about transport formulary, we talk about all analgesics, all antianginals, all antiarrhythmics, antibiotics, all of them, all anticoagulants, all anticonvulsants. These are all things so that when they sit here and have these patients on these medications, you know, when Adam was here doing these critical care drips and medications and so forth, a lot of it was, you know, how do you sit here and talk about every specific drug that we could possibly transport? And you can't. But if there is something that's new in the market, new in treatment, new in modalities, then we'll certainly be disseminating this information to each of you and have some kind of training. Acute coronary syndromes and STEMI, this just talks about maintaining things as set up by the interfacility transport. Hello? Stop. Ron and Andrew are going on the second call. All right? Yeah, bye-bye.
Same street, right, Andre?
I don't know. I'm not even paying attention to that. I don't know. This talks about thrombolytic therapy, glycoprotein 2B, 3A inhibitor infusions, intubated patients, chemically paralyzed patients, transvenous pacemakers, thoracic trauma, specifically chest tubes, blood and blood products as we discussed, and then the blood transfusion records and so forth. So bottom line, what we're getting at with these types of transports is that if they want us to titrate Tridal on the way down, then they're going to have to specifically order that. And the reason that we're setting it up with this is because we don't carry Tridal to do that in the facility. It's not like we can sit here and go on a call and say, well, we've got a STEMI, we're giving them nitro, let's just start a Tridal drip and titrate that accordingly. It's going to be coming from a facility. We want the doctor to order specifically, you know, started at 3 mics, started at 6 mics, started whatever mics, and then just titrate up accordingly to blood pressure and patient symptomology. So as long as that's clearly documented in the order sheet, then we can certainly play around and titrate those medications on the way down to Albany Med or wherever we happen to be going. So these forms, like I said, once Dr. Jagoda signs off on them, we're going to have a book out there so people can start looking through them and getting an idea. Just take comfort in knowing that if we're going to sit here and do these transports, that these physicians are specifically going to be putting these orders in black and white. So you're going to know that if they want you to sedate or they want you to, you know, maintain propofol, then these are things that are going to be ordered specifically on the order sheet for us. What else do you guys have with questions? Anything? Trying to make it easy. I'm not saying that this is easy. I'm just saying, like, you know, when you go in for these calls, we want you to be able to document. We want you to be able to look at this and say, you know, what do we do for a reaction with blood? It's specifically listed here. What do we do when we want to titrate dobutamine? What do we want to do with, you know, patients that have chest tubes? We can literally open up to thoracic trauma and talk about, you know, chest tubes and looking for bubbling and making sure that we have that. You know, Dr. Jagoda wanted to make sure that we have, you know, patients that are on transvenous pacemakers or have transvenous pacemakers, that they also have, you know, the pads in place for the transport. These are all things that, you know, what if there's a failure to sense? This is what you should be doing. If there's an oversensing, this is what we should be doing in regards to that stuff. But that's all stuff that's going to come out in, you know, Chuck Margaritis' lecture. Anything else? Seems like a lot, I know. But I think that once we get, everything, the advantage is that we've got a lot of people that are either have done SCT transports or are currently doing SCT transports, and just getting everybody up to the same speed and page and getting used to these things and feeling comfortable with doing it, going up there. And I think a lot of our patients are going to be, I'm not trying to downplay patients that are transporting out of there, but it could be a patient on, norepi. It could be a patient on, cardine, that we're literally just going in there and keeping the cardine at its existing rate and monitoring the patient's blood pressure and going down there with, realistically, you're out of our formulary practice and it would be considered a specialty grade transport patient.
That's the criteria, is if it's out of our formulary, is what they're on?
Yeah, we're using
Is
this,
that the
this is the
criteria?
formula that we had set up here for, specialty care stuff, so. If it's stuff that, like, yes, we carry amiodarone, we give amiodarone, but if they're on a prolonged amiodarone infusion, it goes over so many hours, like the first 18 hours it's gonna be at this drip rate and so forth, but you're doing continuous monitoring and you have a patient that's considered, realistically unstable going to a higher level of care, then, those are gonna be determined to be an SCT transport. And incidentally, in conjunction to that, if it's deemed SCT and billed SCT, then there's going to be an actual timesheet for SCT. And the reason we're going to have that timesheet is because if you're part of the SCT transport, you're not only going to get paid your hourly rate for the duration of the transport, but you're going to get paid an additional 3 hours at your hourly rate. So basically for 3 hours of that transport, no matter how long it takes, you're going to be paid double time.
Okay.
You follow what I'm saying? So as long as it's deemed ALS, we'll have a specific timesheet. You'll fill that out, and then if Myra says yes, this was billed at an SCT rate, and it's determined to be SCT, then you'll be paid those additional 3 hours on top of your thing, on top of your normal hourly rate. So if you happen to be working, you stay on the clock. If you happen to be off the clock, you get paid to come in for those.
Okay.
Let's say it takes 4 hours, you'll be on 4 hours on the clock, and 3 of
Okay.
those hours will be double time.
Awesome.
And if you were already on duty, the 3 hours will be
Additional.
additional.
Well,
Yeah.
I've been wanting to get with you to I wanted my charting to get better because I've been out of the biz for 2 years and
Yeah.
quite frankly, Schenectady fire charting is not anywhere near this. And I was on the QI team.
Yeah.
So, I'm glad that we went over a lot of that. That really helped me because I want to get better at charting. I was frustrated. So that helped
Glad
me
we
a
were able
lot.
to do it as a discussion
Yeah,
more, because,
yeah.
again, me coming back into Moreau after 6.5 years,
Yeah.
things have changed.
Yes,
so
they had, I had a 2-year hiatus
it
as
was
well.
good to-
In EMS at all, and it has changed. So, thank you.
Good to be discussion based.
Yeah, I appreciate it.
All right. If you guys have nothing, I'm done for tonight. Just make sure you sign the attendance sheet.